How are you? There you go. How are you doing? I recognize you at first. Usually your hair is normally. I'm a little late this morning. I would say it makes me look like I'm about 12.
My name is Dr. Joel Schmidt. I want to thank everybody for coming. This is a great day we're having. I'm not running 6 miles, so it's a day like that for me is a good day. I want to just get some business out of the way. Bathrooms, if you haven't found them already, go out the main hallway straight ahead and make a U-turn when you get to the information desk there. There's bathrooms there. Those are closed. I know. Yeah, the sign says that. And then if you go down this hallway, out that door, past the waiting room, take a right. The bathrooms are right there on your left-hand side. That was number one. Number two, take a break if you need it. We'll be having little breaks to transfer slides and everything. Presentations between speakers, so you can do that between them. Feel free to get up. There's water, there's drinks in the cafe where we'll be having lunch. And when we break for lunch, grab your food, come back here and sit down, because then the food fairies, our dietitians, will be talking to you all over lunch. What else? Door prizes. You came in, if you wanted your name in the hat in the goldfish bowl for a door prize, we're not going to hand them out at the end and call names. We're going to be pulling names legally. And as you check out, you're going to bring your evaluation form that's in your packet. When you turn that evaluation form in, they'll tell you if you want a Jeep Grand Cherokee. We are on live streaming on Google and YouTube and Snapchat and what, I don't know, whatever. So just so everybody's aware, you have to watch what you're saying and doing when you're in front of the camera. Oh, that's only for me. Everybody else. What else do I have to say? That's it. 7 years ago, in 2009, we had our first Family Education Day. It was sponsored largely from funds that we had left over from a Leadership and Learning Collaborative, where basically the CF Foundation sponsored that first Family Education Day. And we had a representative from the CF legal team, only we didn't get the main person. We got the sort of a person that works for the main person. We had James come, so we had sort of the second person come, and then we had somebody from the CF Foundation come down. We couldn't get Bob Bell, we had to get Bruce Marshall. Today we've got the 8. So Beth Suffian, let me read what I've got about Beth. She does, it's probably not a HIPAA violation because she has it all over it. She is a CF patient as well as an attorney. She graduated from undergrad school at Emory University and then got her law degree at University of Texas. And she had a scholarship for children's rights law. She concentrates her practice in health law representing individuals with serious medical conditions and long-term disability claims, Social Security claims, and matters related to access to health care. She also represents pharmaceutical companies as well as national healthcare organizations, manufacturers of medical devices, and other healthcare entities in a variety of legal matters. She's written 2 books. She's had many publications in medical journals and otherwise. And she has many, many, many distinctions, including parents coming up and giving her gifts because of the help that she's provided them. But among her most proud distinctions includes the first annual Transition Service Award, recognizing her outstanding work for young adults with chronic illness. And in 2007, the CF Foundation presented Beth with one of its highest honors, the Alex Awards, presented by acclaimed sports writer Frank DeFord. He's the chair emeritus of the CF Foundation Board of Trustees in honor of his daughter, Alex. You may remember the book, Alex, The Life of a Child, that was written by Frank DeFord about his daughter who died from cystic fibrosis. The award is presented annually to a person with CF who is a role model to others with the disease and embraces perseverance, showing unflagging courage in the face of this challenging disease. And then Texas lawyer named her one of the 40 outstanding lawyers under the age of 40. I'm not going to say when that was given to her. And Time Magazine recognized her as a local hero in 1996 for her service to people with disabilities. Enough said for a brief introduction. That's it.
Thank you. That's such a nice introduction. And it's just great to be here. I am so impressed with your CF team who came to my aid yesterday. I left Houston at 9 a.m. and right before my flight took off, I realized I had not brought my enzymes, which is not a good thing, especially since I'm traveling to New York and not going to go home until Monday. So I quickly emailed the center here to see if they had any extra. And I emailed my center, and my center said, oh, they're not going to have any extra. We'll just call it in for you for when you get to New York. You just have to have 1.5 days without enzymes. So it took me basically 10 hours to get here. And when I got to my hotel, there was a bag and it had a bottle of enzymes in it. So that was thanks to Lindsay, Dina, Katie, and who else? And Maribel. So, I mean, I would just say if your child goes to this center or your child goes to the adult center, I think you're in very good hands. I think that was just extremely, they went above and beyond to make sure I not only had the enzymes, but that I had them at my hotel. I was so grateful and touched for their efforts. And then as I was driving from the airport, falling asleep, I passed the Cadence Theater, which I guess is a regional theater here, and I saw on the marquee it said 4,000 Miles. So that is a wonderful play written by a very good friend of mine named Amy Herzog, and I think it's starting at the end of the month. And I felt like, well, this is really a sign that everything's going to work out. I'm going to get my enzymes, I'm going to have time to do my treatments before I fall deep asleep, and I'm going to have a really nice time coming here. And so then when I got here, I was greeted by a mother of one of the people that we've helped, Miss Falasa, who gave me a beautiful gift and gave me a very special gift of telling me how much I had helped her daughter. So I'm just really excited and honored to be here with all of you. And hopefully I'm going to be able to give you some information that can help you or your children. So the first thing I have to say is that nothing in this presentation is meant to be legal advice about your specific situation, but is only meant as information. And then that the views expressed in this presentation are only the views of me. So they're not the views of anyone on your team, they're not the views of the CF Foundation, they're not the views of the President of the United States, they're just my views. So, so there you go. Okay, so this is a picture of my family. This is my husband, Jim, and he's the one that spoke 7 years ago. He's my law partner and my partner in life, and he's an outstanding attorney. I wouldn't say he works for me. I would say we work together, and he
not
really.
What he said. Not what he said.
Okay, so he might say that on the boss, but he's a brilliant attorney, and we'll talk about one of the major cases he had last year that's helped people around the country with CF. And then that's our daughter, who is now 15, and her name is Isabella. So people usually want to hear a little bit about me and having CF. And when I first spoke, this is my 106th speech at a CF Education Day in the past 20 years. So when I first gave the first speech, I said, I don't want people to think of me as someone with CF. I want them to think of me as a lawyer, and I'm not going to say anything about having CF. Of course, everybody knew that I had CF, and at the end, like 10 people came up, lined up, and I thought, oh great, they all have legal questions. And they all had questions about, you know, when were you diagnosed? Do you have symptoms of CF? What medicines do you take? And so I realized that it would be a good idea to get that out of the way. I don't want you to be spending, you know, the next 35 minutes wondering about when I was diagnosed and things like that, because I would like you to focus on the legal information that we're talking about. So let's get that out of the way. I was diagnosed at 9. That was not because I was asymptomatic, but my sister and I were very symptomatic. But at that time, there was no genetic test for CF. It was just a sweat test. And a lot of people had trouble kind of doing that accurately. And so we kept being sweat tested, and they kept saying, you don't have CF. My dad was a new doctor, he was a surgeon, and he kept saying, I think they have CF. They can't eat, their stomach is terrible, they cough all the time, they have green mucus, and they kept telling him, no, they don't have CF. So then my sister was hospitalized for a kidney problem, and she was 7, and at that time there were 8 doctors who treated people with CF. And the doctor was Dr. Harrison, Gunyan Harrison, and he walked down the hall and he peeked in and he saw my sister and he heard her cough and he went to the nurse's station and he said, you didn't tell me that we have a new diagnosed CF patient. And she said, oh no, we don't have a new diagnosed CF patient. And he said, well, we will in a few minutes. And so he did the sweat test, and of course she had CF, and then of course they brought me in, and of course I had CF as well. So we were late diagnosed, but not because we didn't have symptoms. So the other sister's now 48. She's a professor at a medical school. And then we have a sister who doesn't have CF, who's 39. And I know a lot of people always ask me, well, how is she? How is she affected by having 2 sisters with CF? So for the past 5 years, she's worked for the President of the United States. She was the assistant at Social Security, then she was the presidential appointee at Health and Human Services, and then she was the special envoy for Holocaust survivors. So I think she did pretty well. And I think really if you ask her that having 2 sisters with CF really helped in her development as a person who wanted to help others, as a person who understood how important it was to live each day to its fullest. And so I think if you have children who don't have CF, you shouldn't worry too much, and you should try to teach them positive things through your child who has CF. So I've been married now for almost 28 years, and I've been an attorney for 26 years. So when I was diagnosed, the only thing that my mother had to give us was hot tea and honey to try and stop our constant cough. And so I know Dr. Bell's going to talk later, and someone from your team's going to talk about the pipeline and how many drugs we have to use now and how many drugs that are in the pipeline that we'll be able to use. And so I think it's really important to tell your children and remind yourself that there was a time when there were no medicines. And I think that's really helpful because a lot of kids, and especially teenagers and college students, have trouble doing all their treatments because it takes a lot of time. And if some of the treatments make you cough, you get kind of tired from it. And I think it's really important to make sure your kids know how lucky they are to have the medicines that they have, because you can tell them today, you met someone who didn't have any medicine until she was 16. And even then it was just albuterol and something called Mucimus that tastes like rotten eggs. And so it wasn't a very palatable treatment regimen. So people always ask me, what's my recipes for success? And the main thing is that I do my treatments. And that wasn't, there were short periods of time where I didn't do my treatments when I was in college. But I quickly got sick and realized that I needed to do my treatments in order to stay well. So we hear a lot from people who say, I just don't have time to do my treatments. And so our response is, you don't have time not to do your treatments. Because if you don't do your treatments, you get sick. And if you're sick, you really can't do anything. And so you really want to tie with your children the idea that you need to do the treatments in order to have time to do everything else. And if you don't do the treatments, very high chance that you're going to be sick. The other thing someone was asking me when I came about flying. So when I fly, I wear an N95 mask. So this one has a little filter, but you can get ones without a filter. You can get them online. They're about $2 each. And they give you a very tight seal. It's what people wear in the hospital. My friend who's a nurse who treats people with TB, she wears this kind of mask. So I put this on when I enter the airport, and I don't take it off until I leave. If it's a very long flight, then I'll change masks. I think you can take it off and take a few sips of water or gobble a few bites of food. But for me, when I did not wear a mask and I flew, I got sick every time. That's because the air is recirculated in the plane. So I highly recommend a mask, not a surgical mask that's open, because if the mask is open, what happens? Yeah, everything is flying in. You just don't wear that. That's not what that's supposed to do. But a mask that really, goes around your face. So the other thing that I do is I married someone who is a good cook, and that's very good because I'm a very bad cook. So I try to eat very healthy. I find the things that I really have trouble digesting, and I don't eat those things. So I know sometimes growing up, they said you should eat fried food, you should eat candy, you should drink soda because it was calories, but they were very empty calories. And early on when I was in the hospital, the first time I was in the hospital was 23, 2 weeks before my wedding, which was very exciting. And I saw all the kids and they were so thin, and they were filling up on soda. Like they would just bring them 4 Cokes and they would guzzle the Coke and then they wouldn't drink anything. So for me, I think it is really good to be eating healthy and also to find an enzyme that works. I was on an enzyme for a long period of time, then it stopped working. And now I really think I'm on a good enzyme because actually, look, I have very good weight. This is the most I've ever weighed. So I know you never have a speaker tell you how much they weigh, but I'll tell you. So usually my weight was 105, was about my highest weight, and typically it was about 95. You'll see a picture of me from my wedding where I look really trim. So now I'm 120. So that's the most I've ever weighed. And that's certainly, I think, because my pulmonary health is very good and my enzymes are working and I have a gourmet cook as a husband. So those 2 things. So yeah, like your 5-year-old I know is not going to have a spouse to cook for them, but if you're a good cook, that will help as well. Okay, so we, at our firm, we run the CF Legal Information Hotline. And so we've done that since 1998. And the United States Trademark Office has given us a trademark symbol, which means that everyone who would hear the word CF Legal Information Hotline would associate it with our project. So we've helped almost 50,000 people since 1998, and you can call us for free, and the number is on this card, 1-800-622-0385, and there's also the email, cflegal@suffiangandpessimano.com, and we can answer questions you have about insurance, government benefits, which are Medicaid, Medicare, Social Security benefits, employment, and education. So we cannot answer tax questions. There's only a lawyer who specializes in tax can do that, so we cannot answer those questions. So we're happy to take your calls. We get a lot of calls, like we get sometimes 70 calls on a Monday. So you may not want to call on a Monday. And also what we'd like to do now is if you email me, I will set up a specific time to call you. And that way we're not playing phone tag, and it seems to work a lot better. So if you have this little fancy card that my husband made, which is a cell phone, it has our number, and then too tiny, it has the email address. So I've also given you something for the CF Roundtable. That's an adult newsletter, but parents of kids can certainly subscribe. It's free. You can subscribe online. And I have a column in the Roundtable that talks about legal questions and issues. So it's a really good way right now. There's a lot of, tumult or there's a lot of things going on with Social Security benefits right now. And so on the CF Roundtable blog, I'm doing every month a blog about anything new that's happening at Social Security. So that's a good way for you to kind of keep up with new legal issues. And also it's a really nice newsletter. It has a lot of people that are old and a lot of people that are young as well, writing about different issues, strategies they use to take care of themselves. Okay. And the other thing is that any call to the hotline is confidential when you're talking to a lawyer. you don't have to be our client, signed on a form that you're our client. We have to keep anything you tell us confidential. If you have children that are over 18 and we talk to the child, when you call us, we cannot tell you what the child said to us, okay? So I know a lot of young adults, we had someone call me yesterday, my dad is calling, I just don't want you to tell him, you know, what I told you. I said, no, we won't do that. And we are sponsored generously by a grant from the CF Foundation, and the Honorable Dr. Bell is here, and he was the person who 9 years ago agreed to provide the funding for this project, and without the funding, we certainly would not be able to have the project, and so we thank him for his support. That really has made it possible for us to help a lot of people with CF. But we're not employees of the foundation, and we're just employees of our little law firm, Suffian and Passamano, which is in Texas. So this is part of our team, or this is all of our team. So Jim, Brenda, who is a Spanish-speaking paralegal. So for the team, if you have people that speak Spanish and need someone to talk to them in Spanish, she will do calls with the attorney. Little Amy is our wonderful attorney who last week has won a case at Social Security before the judge in the United States who has the lowest approval ratings of any judge in the United States, and she has won a case before him, which we are told is just impossible to do, but she has done it. So she's worked for us for 10 years. She works basically 7 days a week. She leaves our office at 8 or 9 p.m. She is very committed to helping people with CF. She knows how important it is for people to not only know their legal rights, but to have people who will advocate for them. And then there's Valika, Lacey, and Nancy. So we also run the CF Social Security Project. That's on the back of this. And that allows us to represent people in a Social Security application without charge. And again, Dr. Bell, 5 years ago, agreed to fund this project through the CF Foundation. We don't know of any other disease group that offers this type of program. We never get paid from the client for these cases. Very hard for an attorney to get paid in a Social Security case, so very few attorneys will take the cases. And the CF cases are complicated. You cannot just say, hi, I have CF, where's my check? Our people are young and the medical criteria is complicated. So we're very proud for the fact that every person that we've helped who hasn't gone back to work or gone over the income limits, we've gotten them benefits. So we've now had 3,742 cases total, and we've won every case. So we're told by the Social Security national team that they don't know of any other firm that has won every case that they've ever handled. So we would welcome calls from you about Social Security. If you file an application on your own, we cannot help you. So please call us before you do that. Okay, so this is supposed to be a picture of me when my hair was looking really good, but I don't even think you can see it. But anyway, there are times when my hair looks really good, but like this morning I was so tired and I didn't even look in a mirror before I came in here. So like if people are watching on the screen, you can like cover your screen if my hair is wild. All right, so let's talk quickly about Social Security benefits, because that is a very important government program to help people with CF. So benefits can provide help to children and adults, and they provide a monthly income check and access to Medicaid or Medicare. So Congress about a year ago told Social Security they were approving too many people and they needed to stop, and they needed to review people who were already getting benefits to make sure they really should be getting benefits. And so Social Security has been doing that. So again, we about a year and a half ago, we asked Dr. Bell if we could have funding to do review cases, because these were people we'd gotten on benefits and now 3-4 years later they're being reviewed and they were losing their benefits because they did not know how to navigate the process. And in his generous spirit, he said, said, okay. Maybe I had to twist his arm a little. No, I don't think so. He
We had a
understood.
better hair day then.
He had a good moment and said, yes, we could do review cases. So we can also help you with the Social Security review. And that's really important because Social Security now has $45 million. Like, they have never gotten additional money. I think it's a very long time, let's say 10 years. But they now have $45 million to do reviews, and we are getting like 25 calls a week about reviews, and we used to get 2 every 3 months. So people are being reviewed, and the minute you get the review paperwork, you need to call us because we would like to help with that as well. So most of the people who are applying for Social Security, 70% are over 50. So what does that mean for someone with CF?
Most of the average expectancy isn't that high. Our average life expectancy isn't that high, so most people.
Right, so not so many people over 50. So I'm 50. I told you my weight, so I'll tell you my age. So I'm 50. We hope that, thanks to Dr. Bell's vision of bringing us new drugs, we know people are going to start living much longer. But right now, not that many people over 50. Most of the people applying for benefits are between 18 and 25, and so on their computer screen there's a big red flash that says, young person, scrutinize this application. Okay, what are the medical criteria? Not just saying you have CF. You have to either have a low FEV1, so approximately 50% or below in the past year. And that means all of your PFTs have to be below 50. So if you're rocking at 80, you jump down to 50 and you rock back to 80 because of your great CF team and their medical knowledge, no good. It's got to be 50 or below for the whole year, or 3 hospital stays, or 6 physician interventions. What do you think that means? If you're sick, you go to the doctor and he does some sort of intervention for you. Home IVs or inhaled antibiotics once every 6 months. What's an inhaled antibiotic?
Colistin.
Toby, colistin, Caistin, even off-label inhaled antibiotics. So now people are doing vancomycin, Cipro, blah, blah, blah. There's a long list. It doesn't have to be FDA approved. Is Pulmozyme an inhaled antibiotic? Okay, no. So a lot of people call me, but my kid is on Pulmozyme. Okay, great. I love Pulmozyme, but it's not going to qualify you under this criteria. But in addition to doing this, so you can't just say, I'm on Caistin every other month. Where's my check? Okay, because you also have to show a significant amount of treatment time, and we're talking about 3 to 4 hours. Now, we include cleaning. So, for example, I do albuterol, Pulmicort, Perforomist, Pulmozyme, sometimes hypertonic, and Caistin or colistin. So that's usually about 2 hours if I'm cleaning after each one. So this is being taped, and maybe my clinic could see it, but maybe I'm cleaning after each one, maybe I'm not. But like, I cleaned this morning, I just want to say. So in my defense, I did clean my treatments this morning at the hotel. Okay. But,
and you did already say that everything you were saying was your opinion.
Correct. So I'm sure your doctors would say clean every time. Although I think some doctors are now like clean at the end of the day. I know there's some like really good parents, like my parents would have never done this, but they say they buy all these disposable ones, and so the kids in college just use one and throw it away so they don't have to clean. Wow, I mean, okay, that's great, but I don't think most people are doing that. But we want people to be cleaning when they're applying for benefits because we want the increase of treatment time. Why do we want that if we're trying to show someone can't work?
Because it's not insufficient time to work if you have to do these treatments.
Correct. If you have to do these treatments and you're doing 3 to 4 hours, you're taking a 2-hour nap, you're going to the doctor every month, maybe you're hospitalized every 3 months, then that's very good evidence that it's going to be hard for you to work full time. Now, some people do it, but some people decide that actually for their health, it's better for them to work part time or to not work at all. So this is Buddy the owl, and he was living in our backyard for a long time, and we were trying to get a picture of him, but we could not find him. We could hear him, but we couldn't find him. We kept looking. Finally, we got a picture of him. Here he is. And he, trying to get a picture of Buddy is like trying to find accurate information about Social Security. So you can look online, but there's lots of stuff online that is not correct. And that's why we prefer for you to email or call us. Because if you read something online and it's not true and you lose your benefits, you can't say, I read it online, so you shouldn't take away my benefits. Who thinks that's going to work? Okay, good. This is a very small group, smart group. So most of the people who work for Social Security are not very nice. So I hope no one here works for Social Security. Okay, if anyone works for Social Security, you have to leave now. Okay, all right. Anyone? Okay, all right. So for Social Security, the rules are very important. There are no exceptions to the rules. So people nowadays always call me and say, but there has to be an exception, Beth. There has to be an exception. I said, no, there is no exception on Social Security. So it's the one thing I think where there's no exception. The fact that you're very sick does not mean you get the benefits within the day of applying. And the fact that you really need Medicaid does not mean you get the benefits. You have to meet the criteria. So for SSI, you have to meet the medical criteria and the low income requirements. So you have to meet low asset and low resource requirements if you're a child trying to get SSI or an adult who has not worked enough to get SSDI. So you have to have less than $2,000 if you're an individual and less than $3,000 if you're a family of more than one. One car and one house are not counted. So one car is good, two cars are bad. Was that Dr. Seuss? Someone who has a little kid. Is that Dr. Seuss? I mean, he didn't exactly say that, but you know, he said like ham, one car, anyway. All right, so the value of your second car is going to count as a resource. So we have a lot of families that they have one car and their relatives give them the second car and then they lose their benefits and they lose Medicaid, they lose the $730 a month that they need. So make sure you understand that rule. A motorcycle counts as a second vehicle and a boat counts as a second vehicle. I'm not really sure where, I guess if you're somewhere where you take the boat to work, I don't know. Anyway, so this is my family at our 25th wedding anniversary, and right next to me is my Uncle Heshi, who's a very nice man, and if he had a lot of money, maybe he would be saving it for me, but he's not, but in theory, he could be, and if he was saving money for me and I needed SSI, the money he was saving for me would be counted towards that $2,000 limit. Why in the world am I telling you this? Because about once a week, we have someone who says, no, my child who's 18 has less than $2,000 in the bank. And we take the case, and a few months later, Social Security, or a few weeks later, Social Security says, oh no, Beth, we found the grandmother has started an account and it has $5,000 in it. So make sure if you think your child might want SSI that you don't have a very generous relative that's secretly saving money, because this seems to be something that is going on in our community, which is nice unless you need SSI. So if the money is in something called a special needs trust, it's not counted. But anywhere else the money is, in a living trust, in a family trust, in a happy trust, in a sad trust, whatever you call it, it has to be a special needs trust in order not to be counted for SSI. Once you turn 18, your child's income is counted and not yours. And so we have a lot of 18-year-olds with CF who apply for benefits once they turn 18. Why do you think they want to do that?
So they can be independent.
Right, a lot of people want the 730 to have money of their own. This is my wonderful US philosopher, wonderful lady who knows a lot. And then also people want Medicaid. Why would you want Medicaid?
Medicine's expensive, treatment's expensive.
Right, and what does Medicaid do for you? Medicaid pays everything. So you don't pay anything. You don't pay premiums, you don't pay deductibles. Medicaid pays. And if it's medically necessary, Medicaid should pay. And so a lot of people want Medicaid. Now in 31 states, you can get Medicaid if you're low income. Why is that? I hear this is sort of conservative territory. The guy who drove me over said that. Okay, so so like after I say this, then people are going to get all huffy, fold up their arms. Okay, that's because under Obamacare, which is also the Affordable Care Act, that's the real name, and Obamacare is the slang name, but they are the same thing. Obamacare said everyone who's low income should be able to get Medicaid, and then the Supreme Court said, no, the state should be able to opt out. So 31 states right now have opted in and provide Medicaid to low-income adults, but 19 opted out. What did those 19 have in common? Yes.
Republican governors.
Republican governors, correct. Now we have 3 states that are on the cusp of joining the Western Front. And so Utah is, we think, about to join, South Dakota is about to join, and now I'm going to forget the other one. But if you live in a state and you have CF and you're low income and you're over 18 and you want Medicaid, the only way you can do that is SSI, and that becomes very important for some of the patients who otherwise won't have access to insurance. So let's quickly, so SSDI is if you worked, paid into Social Security for a certain period and become unable to work. So any of you might be able to qualify for SSDI if you became unable to work because of your condition. So again, people are doing really well and people are able to work. A lot of people are able to work in their younger years, and they might find later on that they need to stop work. So they apply for Social Security disability, and they can still work part-time making $11.30, which is really helpful because a lot of people with CF do well working part-time and then having the other half of the day to take care of themselves. And that's the $11.30 is the new amount. So you get Medicare 29 months after you became eligible for benefits. And when you're working, you could trigger a review. So what do you need to do if you're working part-time and you're on benefits? What's the most important thing you should do?
Watch your hours.
Watch your hours. Don't go over the 11:30. Make sure you're working part-time. But also when you go to clinic, make sure you're giving your clinic accurate information to put in your medical records. Because we get a lot of medical records that say, Johnny is doing great. Love the doctor. And when we give that to Social Security, what do you think they say? Well, your client's doing great, Ms. Seffi, and we're terminating benefits. So I think, great compared to the patient that's waiting for a transplant. Yes, Johnny's doing great. But we need to have all the things that Johnny's doing, all the treatments, if he's taking a nap, if he's doing sinus washes, if he has diabetes, if he has arthritis, all the things that people with CF combat on a daily basis. So we need you to tell the doctor what's going on. If you have a kid with CF, we need you to do the same thing, because if you eventually need benefits all of a sudden, we need you to have really good records. Your clinic is very good at doing that, but your clinic cannot mind read, People say, well, my clinic should have known that. I'm like, okay, they're not mind readers. They're great, your clinic is great, but you got to tell them what's going on so they can put it down in your records. Okay, so this is my family a few years ago at the White House, which was a perk of having a sister that worked for the White House. Well, we only got to go to one party, but we did get to go to one party at the White House. And that introduces the Affordable Care Act, also known as Obamacare. They are the same thing. So there's a Gallup poll that says 80% of the people say they don't want the Affordable Care Act repealed. 80% of the people say they want Obamacare repealed. So they're the same thing. We don't want the law repealed. This is the best law that people with CF have at their disposal. And why is that? Look at the last bullet. You can all answer this question. No pre-existing conditions. So prior to January 2014, if you wanted to buy your own policy, could you do it? No, you could only get a policy if you had CF if you were employed, or your parent was employed, or your spouse was employed, or you were on Medicaid or Medicare. So under the Affordable Care Act, there's no pre-existing condition. If you need a policy, you can purchase one. In addition, your child can stay on the policy until 26. So they can be married, they can be employed, they don't have to be disabled, they don't have to be a full-time student. So we think that like everybody was hunting when this section was discussed on the floor of Congress, because this is a really good section and everybody is for this section. So even people right now who say they will repeal the law on their first day of office, although actually the president cannot do that. So I'm not sure how someone who's running for president can say they will do that, because actually the president cannot do that. But anyway, I guess if we suspend the Constitution on the first day that person is president, maybe they can do that. But even that person says that the next thing he would do would be to reinstitute this section of the law. And that's how popular this section is, and it really helps a lot of people with CF. So this is my husband cooking. He doesn't usually wear the chef's jacket, but he put it on for the picture. So you can see he makes me really appetizing food. And that's to say that for insurance, you know, he puts a lot of ingredients into his pasta dishes. And for insurance, there's lots of different laws that interact and come into play to help people with CF. So one of the laws is COBRA. So if your child reaches the limiting age, you get 36 more months on the policy. So you really get the policy till 6 or 7, 20, end of 28th year. But you do have to pay the premium. So if the child is incapable of self-support, only working part-time, he can continue the policy under state law. And that's very helpful as well. So this is my daughter's Girl Scout troop, and they were doing a project on organ donation awareness. Because they're obviously influenced by my life and the stories I've told my daughter and her friends about people who need transplant. So caps on coverage, that introduces the section on caps on coverage. So Affordable Care Act says no more caps on coverage. So in the past, before January 2014, your kid was sick, they used up a lot of insurance money, they came to the $1 million cap, and they could not get any more coverage. The child needed a transplant, and they had no coverage. So that was a very bad thing to have caps on coverage for people with CF. So now we have no more lifetime caps on coverage. Now they still can exclude some services. There's 45 services that cannot be excluded. So drugs, hospitalization, doctor's visit, blood work, x-rays, and there's a list of 45. But there are some things that companies like to exclude, mainly physical therapy and home nursing visits. Those are two big ones. And those can have either caps on number of visits or can be excluded. We don't see a lot of people excluding those, but those are the exclusions that we usually see. So the individual mandate is very important because of no pre-existing condition clauses. And then this is us at Christmas. See, I'm looking so young in these pictures. Someone in my office was like, you need to update the pictures, Beth. I was like, no, I don't. Why do I need to do that? So anyway, this is what I looked like when I was young, which is basically before last year. So this is Christmas, and I just say that the Affordable Care Act gives us a sort of an ongoing Christmas gift of health exchanges. So that's a government site where you go on and you can purchase a policy, and you can be a citizen or a legal immigrant. Illegal immigrants cannot purchase a policy. You can be a small business. And this is sort of what it looks like. They've modified it a little. You click on apply now, you put in some information, and it tells you how much you get. How much you pay for a policy. So policies are cheap because the government provides a subsidy if your income is below 400% of poverty. So that's about $47,000 for a family of one and about $96,000 for a family of four. So the policy at the top says $69 and the person's getting a $212 subsidy. So that's really helpful for people. Okay, here's when I was thin and not having enzymes that worked or not having much treatment, so I was very thin. So this is my wedding picture, and that was my husband's mother's dress, which was very nice. So that is the levels of coverage: bronze, silver, gold, platinum. So bronze is going to be bare bones, but if that's all you can afford, then that's what you should get. But if you could get silver or gold, those are typically going to be better coverage, less cost share. The main thing you want to do is you want to make sure your clinic is covered. So who's the best person to tell you that?
Clinic.
Correct. This guy is like winning the prize. If I have a prize, you're going to win it. The clinic. So don't ask the insurance company because they're going to say, "Oh yeah, Blue Cross. We cover VCU. Yeah, sure." But then later on they say, "Oh, not the one you chose. We have 30 different products, not the one you chose." So you want to make sure you talk to the clinic. Is your center covered? Okay, so we're getting towards the end. This is my daughter running track, and I always like to say, okay, this is the end. So my husband is like, okay, when you talk for more than 30 minutes, it's annoying. So I'm like a little over the 30 minutes. I've totally lost all track of the time. But anyway, we're close to the end. So special enrollment in the Affordable Care Act exchange. If you move to another state, have a change in income, loss of coverage, or change in family size, you can purchase a policy at any time. And 800,000 people did that last year. So don't feel like you've missed the window. You've had a change in circumstance. You're okay in terms of enrolling. So these are the sisters. The middle one is the one without CF, and she's actually getting married next month. So we're all very excited. And so this talks about education. That's the slide to introduce education. So my parents were the first born Americans, and their parents were immigrants. And to my parents' families, education was the most important thing. Like my grandmother didn't buy clothes for like 20 years, saving money for my mother to be able to go to college. So that was passed down to us, and I think education is very important for people with CF, regardless of disease severity. But it does become difficult if you're sick and missing school to keep up. And some schools are not so good at trying to help you. So I don't know if anyone here has experience with that, but we get quite a few calls from people saying that the schools are not being helpful. So it's important to know about the two federal laws that can help you, the Individuals with Disabilities Act and the Rehabilitation Act of Section 504, and those also can modify things in college or graduate school. So what are examples of modifications? Turning homework late, taking exams late, having assignments sent to your house, having a homebound teacher, a private room in college. There's not a list, it's what the child needs to get a reasonable education. So a lot of times you're going to go to your school, you're going to say, I saw this wacko woman from Houston, she told me I have some sort of rights, here's what I want. And the school's going to say, oh, I'm sorry, we don't know who that is, but she's mistaken. Because we have a school board policy that says you cannot carry medicine on you if you're in high school. And so what you need to tell them is, this is what Beth told me. Look at the sky, look at the ceiling. See the ceiling, everybody? See the ceiling? Okay, that's federal law, okay? See the floor, that's state law. Look under the floor and go way down, and that's school board policy. Okay, so federal law is much higher. That law trumps any laws that come under it. That's the first day of law school. You've all now been to the first day of law school, okay? So school board policy is not going to trump these laws that are on the ceiling, and you need to remind the people at the school that that's the case. You have meetings with them, and if they don't go well, you can call us on the hotline and we can give you information on how to file for a due process hearing where you hopefully will go before someone who has a brain and understands the law and will tell the school that they have to give you the accommodation that you need. Most of the accommodation people with CF need are free. So taking the exam later, modification of not so much homework, having a project due later, those are all things that are free. And they don't like to do them, but they're obligated to do them under the law. And what we see for a lot of, especially high schoolers, is they go into the hospital and they get very behind and they get very discouraged and they want to drop out of school. So we unfortunately have more and more people calling us with this situation. So we want to make sure that you have in place, if the child is sick, what's going to happen with the homework? How can you prevent the child from just feeling overwhelmed while they're sick? Nobody needs to be taking an exam while they're on IVs in the hospital. So some people say, well, the school says they'll give me the exam and Sally can take the exam in the hospital. That's like the worst idea I've ever heard of, except for repealing the Affordable Care Act. So no, we don't want that, and you don't have to have that, and make it a little easier on your child that he's focusing on getting himself better, and he's going to take the exam. Guess what? The exam's not going anywhere. He can take the exam, or she, when they get out. Carrying enzymes on themselves is important for a lot of people. They're not going to take the enzymes if they have to go to the nurse's office. And also, we are very against kids going to the nurse's office every day to get their enzymes. Why is that? No, I'm sorry, you're maybe not getting the prize. Okay, cuts down time. Okay, you're not getting the prize either.
Exposure.
Yes, exposure. We are sending kids with CF to the place in the school where everyone who's sick is waiting for their parents to pick them up. How smart is that? Okay, that's not a very good idea. And the teacher can have the enzymes or someone else can have the enzymes. But I mean, there's a lot of very prominent physicians who support me on this. So I will say that that's a very bad idea. Okay, so that's another thing you should work on. Vocational Rehabilitation Act is a federal law, and that provides for money for people to go to a state college or attend vocational training. That's really good if you don't have money for your child to go to school. If you have money, please don't use this money. Let's save it for people who need the money. You can call me for more about that. So now I'm at the end, but I did just want to talk about two other things, and I don't know, what time am I done?
You're fine.
Whatever you want.
Oh my God.
Don't ever tell her that. Don't tell her.
Dr. Bell's like looking at his watch, like, when is this over? All right, no. I just have two more things, and then this thing, and then I'm done. All right, so the first thing I want to talk about quickly is so under employment, if you didn't have a slide on that, since we have a lot more time, we can talk about it. So employment law protects people with CF against discrimination because they have CF. And that's called the Americans with Disabilities Act. And it also protects you all if you're associated with someone with CF. You can't be discriminated against because of that association. So those are very helpful laws. You can get a reasonable accommodation if you have CF and you're working. So things like no smoking in the workplace, having a drink at your desk. It's very hard to get working from home. Occasionally you can do that. A lot of people with CF seem to feel like it's really good if they can work at home at least half of the week. And then very hard to get extra time off. if you've already used up vacation and sick time. And so that's a really big issue. If you've used up vacation and sick, you're not eligible for family medical leave, which gives you 12 weeks of unpaid leave, then you can be terminated. So that, a lot of people call me and say, no, Beth, I can't be terminated because of the Americans with Disabilities Act. And I say, no, unfortunately you can. So that's really important for young adults who are starting in the workforce, because they tend to drop off on doing all their treatments because they're working, and then they get sick. So another reason why it's important to keep up with your health care is that if you're sick too much, they can terminate you. So one of the things we're seeing recently, and I've been seeing a theme, and so this is the first time I've talked about it, but I'm going to add it, is this idea of sort of adult bullies. And we see that in the workplace, and we seem to see that in schools. And these are people who just want to make life very difficult for people with CF, either a school administrator or an employer. Or maybe an insurance company, someone who works for an insurance company, or a Medicaid agency who really wants to make things tough. And what I found when I was dealing with some bullies last year was it was very stressful. It was very hard on my health. And when I talk to people the past few months, there seems to be a lot of situations where people are really bullying them, either in employment or education or insurance. And so you really want to reach out, I think, to us, to your team, to make sure that you understand your rights so you can advocate for yourself, because I think that's the best way to combat a bully, is with actual facts and with your rights. So that brings me to talk about the Arkansas Medicaid case that my lovely husband did last year, where we sued Arkansas Medicaid for failing to provide Kalydeco to 3 girls who were on Medicaid, and they had G551D, the mutation that people have who use Kalydeco. So these girls were the only girls in the United States after 2 years of Kalydeco being available that did not have the drug. And they had tried to have legal counsel who didn't know what they were doing, and so they were getting nowhere fast. So we agreed to represent them for free, and my husband spent 9 months of his life working on that case, and he got the first girl the drug within 30 days of filing a federal civil rights suit in Arkansas, and the next 2 girls 60 days, and the next girl 90. And then we had about 8 more months because the people at Arkansas Medicaid really did not want to pay for Kalydeco. They felt like it would open the door to paying for Orkambi, and they put up a lot of illegal requirements for patients to meet in order to get Kalydeco. So at the end, we had a court-ordered settlement, which is very rare, that was published. And now that case is being used not only by people with CF, but by other disease groups as legal precedent for the idea that Medicaid has to pay for medically necessary treatment, and they cannot put sort of false roadblocks up to prevent people from getting the drug. And so I think it's really important right now to understand that there are insurers and Medicaids that don't want to pay for the drugs that we need to stay alive. But we need to fight those people, and we need to stand up and say, not only rich people with CF get Kalydeco, because these girls had families and they were young. One was 14 and she'd been hospitalized 7 times in the 2 years prior to us representing her. And, you know, we really felt it was important to stand up and say, this is not right, and someone must speak out for the people that have no one to speak out for them. So I encourage you to reach out to other people who may need help. You know, today you're here with parents, you're going to be walking around. Reach out to other people, and reach out to your clinic to tell them you're willing to talk to other parents who might need help, you know, or just support on the phone. I think it's sort of like, obviously, the Arkansas, you're not going to be able to bring a federal civil rights lawsuit if you're not a lawyer who knows how to do that, which is basically Jim and I. But you can do other things. You can provide support to other parents who might just need someone to talk to. So that's what I wanted to say about that. And then lastly, people like me to talk about this. I talked about it a few years ago and people were like overwhelmingly excited. So I've kept the slide in. So living with CF can be very hard. So I sometimes see these rosy things on the internet about how great it is to have CF and everything's rosy. And I think that it's important for us to accept that CF can be very hard. And I don't think we should try to sugarcoat it. I think we should, fess up to the fact that it can be really hard. But for me, accepting that I had CF was very helpful to me. Not hiding it from others, which I did until I was about 27, which I know is hard to believe. But accepting that I had CF was very important. And then embracing CF for me has been really life-saving because it has allowed me to connect with people, for example, on the CF Roundtable. Everyone on the CF Roundtable is one of my best friends now. I have a lot of people that I keep in contact with as friends on the internet. I know people are afraid of cross-infection, but we have this wonderful internet and we have phones. And that's a really good way to connect with people. I mean, I have people I'm very close with that I've never met, but I consider them very close friends. And I think that's a really helpful way, especially for teenagers that might be feeling very alone, to connect with somebody else online. Ask your clinic, is there another person who you think my child would be good to talk to? So accessing information and support is very important. So you have our hotline card, and I know you have something from Compass, which is the new part of the CF Foundation that can help you with case management and accessing copay assistance. There's lots of copay assistance out there, and Compass is great at helping you access that information. Really taking care of yourself is key. So when the medicine is in the bottle, it really can't help you. So you have to pour it into the nebulizer and you have to suck it up. So it's not going to help you if it's there. And if your kid has had a month where they're not doing treatments, and then they start again, and then the young adult tells me, it's not working, Beth, I don't feel any better. I'm like, it's only day 2. Okay, like give it a bit of time, give the stuff some time to work. I think learning when to say no is important and very hard. I was talking to someone earlier that said, her daughter's friends are all working and they all go out at night and she's working part-time, but maybe she's too tired to go out at night. It's hard to say no to doing a lot of things that everyone else is doing, but sometimes it's important to do that. And that's a hard skill to learn. I think, of course, the bottom line is enjoy your life. Enjoy being with your child. If you have a young child and you wake up every day and you say, this is the worst thing that could have ever happened to me, my child has CF, it's going to be a very long road for you. And frankly, I don't think it's the worst thing anymore. I mean, yes, we have about 20 clients right now waiting for transplant. And we have 20 clients not eligible for transplant who are very sick. And obviously, CF has been right now very bad for them. But they've all lived very good lives. And I think you'll hear from Dr. Bell and your team. There's lots of good things on the horizon coming up. So I think you should say, how can we make my child's life the best life it can be? I think you've got a great team. I think the CF Foundation is also a great team member to help you make every day with your child a very happy and special day. Thank you.
I did not plan on introducing Mike, but I wanted to personally just thank Beth for coming. I know how travel can be difficult with work and with family and everything else. I just want to...
And our hair.
And your hair. Coming from somebody who never has a bad hair day. And you can tell your husband you're 30 minutes took an hour. All right, Michael, you can introduce yourself.
want to thank Dr. Schmidt for that kind introduction. Let's see.
Second one, third one above that. That one.
Okay, so first of all, I just, everybody can hear me okay. I want to echo what Joel said about having the 18-minute for guest speakers today. I mean, I find this really exciting. I had Beth, when I was in Atlanta, she came and spoke then, and you know, really is a great speaker. And I've also been on panels with her as well, and find myself following her and really falling flat, you know, sort of the classic sort of thing of following somebody who's too good. So I'll try to do my best. What we're going to do today, for those of you who have been here previously, this is actually largely a rerun of what I like to do every year at the programs, which is basically to just kind of tell you a little bit about what's going on, and specifically what's new about what's going on here at our center, and also talk about our outcomes, because I think that this is really an important part of the group really understanding a little bit about what we're trying to do in terms of our goals. So I'm going to be reading along these slides along with you, so I'm going to be kind of looking back and forth. We didn't quite figure out a good position, but I'll give it a try. So basically, just to remind you all about our faculty in pediatric pulmonary. There's myself. There's Dr. Boy now again. So you all know Dr. Williams and Dr. Schmidt and myself from the clinic, but in the context of inpatient care, you're going to meet some of the other doctors. Dr. Boy now, who joined us around the same time, a little after I came from Duke. Dr. Rubin, who was here briefly. Dr. Schmidt, Dr. Williams. Okay, and then I want to introduce you all to a new physician who came to join us this past summer, Dr. Brockbank, who is a pediatric pulmonologist who started out here in Richmond, went to Cincinnati to be trained, and then also did an extra year in sleep. And so most of his efforts really at the outpatient setting are focused on pediatric sleep. But he's also potentially going to be somebody who you might be covering the inpatient unit. But he's been a fantastic addition to our group. And the whole idea of sleep issues in CF is one that hasn't really been explored completely, and so he may help us to do that a little bit. The other new physician I want you all to know about is Dr. Jonathan Ma. Now, Jonathan Ma is a pediatric resident who's finishing his residency and is going to be joining us as our first pediatric pulmonary fellow. We were just accredited this past year to as a fellowship program, which means that we are now going to have the opportunity to train new pediatric pulmonologists. And he is especially interested in cystic fibrosis. He's actually already been working in Dr. Rubin's lab doing some research there, and we just found out the day before yesterday that his fellowship is going to be supported by the Cystic Fibrosis Foundation. So we're really excited about that. So you'll be seeing him either in clinic or in the hospital as well. And if he looks young, it's because he's young. Okay, so then there's the clinical staff that you all know. So I just have a few little pictures of everybody, and everybody is here. Mary Dell, Jim. We call him Jim. His name is Robert, but we call him Jim. So it took me a couple of years to figure that one out. Deanna, Dina, and Rebecca. And we have some new staff in pediatrics. Now, Nadia has actually been with us for almost a year now and is actually almost leaving soon. But she's, we're going to talk a little bit more about her role and the role of the psychology student here. But we've had pre-doctoral students in psychology working with us for several years. Nadia has been with us again, for almost a year now, she's going to be leaving. But again, this is my opportunity to introduce you, those of you who haven't met her. And the other new staff is Katie Lawrence, who is our administrative assistant. And she's here somewhere, right? She usually is.
In the lobby.
Oh, she's in the lobby. Okay, we can usually tell when she's around. She's probably the most bubbly one of the group. But anyway, she's been a fantastic help, and she really helped to orchestrate this meeting for us. The other new staff is Meg Lassard, who's our new research coordinator. Again, Matt, who was with us for many years, left, and we hired Meg just a few months ago. How long have you been with us now? Two. So she's been really fantastic, and we'll talk about this a little bit later, but we are growing our clinical research enterprise quite a bit, and there's going to be new colleagues for her in the near future. And then the other person who hasn't exactly joined with us yet, but I want to give you a little bit of a preview of her, is Robin Everhart, who's a PhD clinical and research psychologist who I've been working with in a few other areas here at VCU. Robin has previous experience with cystic fibrosis and asthma actually as well, and she's going to be joining us again through a grant that we're getting from the Cystic Fibrosis Foundation as for a mental health coordinator. I'll talk about that a little bit more in the next few minutes. So the other big new thing that we're excited to show off and to talk to you all about is our new digs. Our new pavilion building that's been several years in the making just opened a couple of weeks ago. I think we've had 3 clinics there now, right? We've had 3 clinics there now, and we just did a little tour for the local CF chapter board and people there just the night before last, and that was a lot of fun. And you're all going to be seeing it soon. But I'm going to give you a little bit of a preview here right now because we're really excited about this. Is an opportunity on the one hand for us to be in a pediatric facility. Now again, this is just outpatient; it's not inpatient, but it really feels good as a pediatrician to be in a pediatric setting. Okay, and I came here from a children's hospital, been hanging around with adults, and now we're back into a pediatric setting. Again, similar in some ways to what this building here at the Children's Hospital Richmond campus on Brook Road is. It's nice. It's obviously something that's set up for kids, and that's what we have here. And the other thing is it allows us to work all together with our colleagues in other subspecialties within pediatrics. Our offices are all together, and the clinics are all together. So in terms of being able to collaborate, it really facilitates that quite a bit. So this is what the Sky Lobby. I hope you can see these pictures. I went around taking a bunch of pictures in the last few days and realized that my pictures weren't nearly as good as the ones that the professionals had taken and put on our website. So I got rid of all of those pictures, and I'm just using the ones from the website. So we have a website that gives you a more of a dynamic tour. But this is the first floor, so when you first come in from the parking, the other thing I need to show you is this. These 2 floors that look a little bit funny, that's parking.
3 floors parking above ground.
Yeah.
4 floors underground.
Yeah. So as opposed to what everybody's experience has been at VCU up until now, you're going to be able to just drive into the building, park your car, or have a valet park your car, and it's going to be way easier. And this is something that for those of you who've done, for people who don't do this, they don't realize. It took me a year or two of people talking about parking at VCU. I didn't quite realize what the issue was, and I do. But anyway, so that's all going to be different now. Okay. So anyway, so when you come in from the parking lot, you come into the Sky Lobby here, which is the first floor, and you see there's an information desk there. There's a break from the elevators that come from the parking to the elevators that go up to the clinic, and that's set up there for security reasons. There's this nice little outside area that you can go out to when the weather's nice. here. And then when you get up to the 4th floor, you come in, and the check-in desk is right over here. This is a little bit of what the waiting area looks like. There are 4 pods on each floor. There's the 3rd floor and the 4th floor. We're on the 4th floor. There are 4 pods. I think it's a little bit confusing when you first get up there. Hopefully, after a while, it won't be so confusing, but I can imagine that it might be a little bit. We are Pod E, which Dr. Schmidt has had great fun with, coming up with all kinds of potty humor and about that, but it does make it easy to remember. It does. That's right. You either come to the potty or you come to potty. Anyway, it does make it at least easy to remember which pod you're coming to. And then when you actually come in to see us, we have, this is what an exam room looks like. They actually use a fisheye lens to make it look a little bit bigger than it really is. But it's a good size. It has 2 doors, one that the patients come in and one that that all the providers come in from the other side. Again, we're getting used to the setup there, but again, the bright colors makes it kind of nice. And then the high point of your visit will be coming to the pulmonary function lab, which is the best seat in the house to see the view. We've got these floor-to-ceiling windows there, and as Joel was saying, we're a little bit concerned that everybody's PITs are going to drop for a while because they're going to come in, they're going to be distracted by looking out at the view rather than paying attention to blowing as hard as they can with Jim and Deanna trying to coach them. But again, you can see it's all very pretty. Okay, so then the other thing that's new that we want to talk about a little bit is the mental health coordinator, and this comes out of a number of years of work that people in CF have been doing, and I actually played some small role in working with some others to really establish the prevalence of mental health, behavioral health issues, anxiety and depression, both in patients and in the parents. And having recognized that and recognizing that as a morbidity in and of itself, in other words, a weight in and of itself, but then also a problem that makes it that much harder for CF patients to be able to take care of themselves. The CF Foundation has recognized that that's an issue that really needs to be recognized and dealt with. And so the Cystic Fibrosis Foundation has actually established a program to support the presence of mental health coordinators in a number of CF centers. There's about 70 that got funded in this last application, and the pediatric program here was one of them. We're going to be supporting the adult program a little bit, even though they didn't get funding for a similar role here. But Robin Everhart is as I already said, is a PhD clinical psychologist working on the faculty at VCU. Now again, we have had psychology graduate students working with us for some years, being supervised by Matt Bitzko, who's a clinical psychologist whose primary funding actually came through the Massey Cancer Center. And he's been supervising the students up until now in a sort of distant way. So Robin is going to be much more involved in the screening process, in providing treatment and referrals for parents and children who are found to screen positive, but also in a more proactive way to work with us as a program to help develop, again, more proactive sorts of perspectives on helping with parenting issues, in helping with feeding issues that become problematic, especially in younger kids who become kind of recalcitrant around mealtime. And then also helping with issues around adherence and in helping CF patients really to figure out how they can best get their treatments in and take care of themselves. So she's going to be starting with us in the next couple of months, and so she's somebody that you're all going to see. And again, we're going to continue to have graduate students like Nadia coming along with us as well. So we're excited about that. Something else we've been working on, especially in the last year or so, has been our transition program. Now that we have a well-established adult program, the idea that we can come up with a smooth transition from the pediatric program to the adult program has been a challenge that we've been taking on. This is my personal and professional view of teenagers. And so, you know, they do present challenges, but we can embrace those challenges. And so this has been really kind of driven and led by Dina, and we've made use of some resources that have been provided actually through Gilead, and along with a number of consulting CF providers nationally to develop this so-called CF RISE program, which we haven't really used completely, but we've borrowed pieces from it that we thought were particularly suitable for us. And again, the goal is to prepare and empower patients, young adults, teenagers who are beginning to transition to adult care, and specifically to identify areas to improve teens' knowledge and ownership of their care. So it includes a complete assessment of knowledge of CF and the issues around CF care that teenagers need to know in order to be able to take care of themselves. And so we systematically assess all of those sorts of things. And then the other part is really above and beyond that. It's really all about, well, now you may know what you need to know in terms of knowledge about CF, but do you know really how to take care of yourself? Do you know really, you know, how you translate that knowledge into your own practice, which is a theme that I like to go back to in a number of ways. We'll talk about that in a few minutes again. But again, so this is all about how well is the child beginning to take responsibility for their CF care and recognize the sorts of things that they need, and going along with, you know, teaming up with the parent to try and figure out how to gradually transfer that care to the child. So this is a checklist that helps us to evaluate that, and then from there we begin to work on some of those different things. So this is a good segue into reintroducing the adult CF team, people that you have been around, who you probably already know, for those of you who've come here, or for the adults who are joining us online. Dr. Chowdhury is our adult program director. Lindsay, who's here, manning the video over there, is really right-hand person, nurse coordinator. And Megan Clayton, who I don't think is here, is in this right there. Sorry?
She's watching on the internet.
She's watching on the internet. Hi, Megan. And then the new people that we'll introduce are Brett Waltney, who's the dietitian, who's back here. And Carly Barrows, who's a social worker, who's also back here. So they have joined the program in the last year or so, and are actively working along with the team. And this is, again, while we have moved into our new digs over at the pavilion, they're in their old digs in Mayland out in the West End, which is actually still a pretty nice place and has even better parking than we do, but still. Okay. So now I just want to, again, update you on a little bit of what's going on with research at our place. So we have a couple of active basic and translational researchers. That's really basic. You know, basic research is, you know, kind of the Dr. Frankenstein stuff with the bubbles in the lab and all that sort of stuff. It's lab-based stuff. Translational really means taking that step from what is starting to look good in the lab to what might really start to work in the bedside. So it's beginning to test out ideas and see if they're really ready to be tested on a large scale. So Dr. Rubin and Dr. Voynow are actively involved in that. And again, Dr. Rubin, who has a long-standing history of trying to understand and treat mucus clearance disorders, including cystic fibrosis, Mucus is his byline. Mucus is what he had on his license plate, at least when he lived in North Carolina. I don't think that mucus is on his current license plate, but that's always been an area of special interest for him. And Dr. Voynow also works on airway mucins, which again make up mucus, is interested in a number of other areas that are specifically of interest in CF. And some of the active studies that are beginning, either ongoing or beginning that are coming out of their lab. And again, these are maybe more translational, because if we start talking about some of the real molecular basic science stuff that they're doing, I'm not very good at explaining it, and y'all may not understand it very well, especially the way I explain it, so I'm not going to try and do that. But some of the things that they're starting to talk about, we have a little project looking at the effect of nasal humidification during inpatient treatment of pulmonary exacerbations. Dr. Rubin, who has all kinds of international connections, has recently teamed up with a group from Italy that are looking at a molecule that has been around for a while in different ways that looks like may have some novel effects on CFTR as a modulator, and maybe have some immune effects as well, beginning to explore that. Dr. Voynow has been working on the evaluation of heparin analog and its effect on mucus inflammation. And these are all studies that are initiated by them and that we're starting to work through as they make the transition from the lab to the bedside. As far as clinical research, again, we've become fairly active as a member of the Therapeutic Development Network, which joins us with 81 other centers around the country to help participate in clinical trials and see through the development of various new medications and understand better how to take care of CF. This pipeline is copied off of the CF Foundation website, so I would invite you, if you want to get a better feel for everything that's going on nationally, just to go there. But the idea here is that the longer the bar is, the closer it is to patient access. So the bars that are at the very end are drugs that were developed because of the CF Foundation's involvement. So this is where we have up here the CFTR modulators like Kalydeco and Orkambi. And again, you can see there's a number that are coming. And then we have a variety of drugs for inflammation, antibiotics, mucus alteration, and pancreatic enzymes, and so on. So we're involved. I'm going to show you a little bit about what we're doing here so far. In addition to being part of the Therapeutic Development Network, I'm also proud that we are one of 12 centers that are participating in what we're calling the Success with Therapies Research Consortium, which is a group of centers with researchers that are interested in how do we really best ensure that the medications that are being developed out of the labs and out of these big research enterprises are best used by patients, and how patients who are being overwhelmed with all of the new medications and new treatments, as well as the old treatments, how they can really incorporate that best into their day-to-day lives. So this is the list of the studies that we at VCU are currently either actively participating in or involved in startup towards participating. So this is, again, an anti-inflammatory drug. We have a couple of studies around pancreatic enzymes. We have a number of studies about CFTR modulators. We have a study on eradication of Pseudomonas, inhaled antibiotics. Again, here's another pancreatic enzyme. I should have put it up here, but this is about patients' reactions to pancreatic enzymes, and then tracking whether patients get an unusual complication called fibrosing colonopathy to excessive use of pancreatic enzymes. Through the Success with Therapy Research Consortium, we're about to get involved with what's called Design CF, which is focusing on trying to help families improve nutritional intake in their patients, in their children rather. And then these are a number of investigator-initiated studies, some of which are funded by the CF Foundation, some of which are funded by other means. Again, anti-inflammatory, palliative care. This one's Dr. Boynow. Palliative care is Dr. Schmidt. The GI symptom trackers, I'm working with that. This is the nasal humidification study of Dr. Rubens. We also have, every time you all give us a little bit of sputum for culture, we have already asked your permission to use a little bit of that to just keep on hand for doing other research studies in the lab. And then Project Uplift, which we're going to be getting up and running on very soon, is a group-based approach to dealing with mental health issues that I have funding from the CF Foundation to do. The other thing I just want you to know that we do here, and this isn't something that's actively involved with patients, but I actually am involved through a couple of databases, and most particularly I'm a member of the Cystic Fibrosis Foundation Comparative Effectiveness and Registry Committee, and we do a lot of statistical and secondary analyses of data that are in the Cystic Fibrosis Registry, which is a tremendously useful repository of data on really what is going on in real life in the patients as opposed to what's going on in different research studies. So it gives us a glimpse of what the experience is of CF patients and gives us a better idea of how different treatments and different aspects of care may be impacting on patients. And so this is just a list of some of the studies that I'm actually involved with right now, along with collaborators around the country, to try and get an understanding of hospital versus outpatient treatment of pulmonary exacerbation, the role of tobacco smoke exposure specifically in low-income families, what pancreatic enzyme dosing seems to work best in, again, real life, benefits of starting pulmozyme or hypertonic saline early in infancy, the impact of ivacaftor in clinical practice, issues around transition from pediatric to adult programs and their impact on outcomes in older patients, and whether the distance from the CF center has any impact on outcomes. These are some of the things that we're looking at using the CF registry. Okay, and now what I want to do is I want to talk to you, I want to spend a little bit of time now talking about one of my favorite topics, which is how we can improve clinical outcomes in CF patients with the tools that we have available to us right now. So when we talk about clinical, and again, those of you who have been to these sessions in the last couple of years, some of this is going to be repetitive to you, but so I apologize, I tend to be repetitive. So when we talk about clinical outcomes, specifically what we're talking about is, again, what is it that really we can use to measure how healthy, how well CF patients feel? So the best correlates with health and well-being and longevity in patients with CF are lung function, as measured by Jim in the PFT lab, and specifically that FEV1 number that we tend to harp on a little bit, forced expiratory volume in 1 second. And then there's nutrition as measured by body mass index. So those are the two numbers that we use a lot of to see how we're doing. So while research is providing us with the tools to improve the health of people with CF, the challenge for physicians who take care of CF patients is really to determine how we can best use those tools. And we know from looking at data from places like the Cystic Fibrosis Foundation Registry that CF centers do show some variation in their ability to do this. We all have the same tools. We all have the same knowledge, for that matter. But how we actually are able to translate that into practice is different across different CF centers and is revealed by looking at average lung function of everybody in the CF center and average nutritional measures like BMI in the CF center. So if you go to the Cystic Fibrosis Foundation Registry, cff.org, you can actually, it's gotten harder to find, though, I have to say, with some of the changes that they've made in the registry, but you can find something that gives you not only some graphic and numeric representation about how any one CF center is doing, like us, and you can actually see how everybody else is doing, any other CF center is doing as well. So this was something that the CF Foundation decided was a good idea probably 10 years ago or so, in order to, again, make sure that patients really understand everything that they should understand about the disease and its care. So this, just to give you an idea, these two graphs here show a 5-year trend. In this one on the left is how well are we doing? We should be screening everybody age 10 and above for CF-related diabetes. And how well do CF centers do? So I have to say that the goal for the CF Foundation that they sort of set experts who decide what is a reasonable expectation, or at least a expectation to aspire to, says at least 95% of patients over 10 should get your yearly screening for CF-related diabetes. So this is how we at VCU have been doing over the last 10 years. And I have to say, generally, we've been doing pretty well. So you can see in 2014, which is the last data that's available on the registry, we were up over 95%. So that's above that national goal and clearly above the national average. This is guidelines for care in children, which is the percent of children less than 18 years. So this is just the pediatric data I'm showing you here, who are coming to clinic at least 4 times a year and having at least 2 lung function tests and at least 2 sputum cultures. Now, actually, we all clinicians believe that should be done more often than that, at least the lung function tests and the sputum cultures. But that's at least a basic minimum. And you can see that actually it's a little bit hard. And this is partly because it's hard sometimes for patients to come in that often. But we've been doing gradually better through the years. And again, in 2014, we took a nice jump, and we were up at about 86%, which is not quite at the national goal, but much above what the average is around CF centers. So those are processes about how we take care of patients. And some of them. Now, this here is actually what I think is more important. And this is the actual outcomes, okay? And you can see, very frankly, that we have in the past maybe not done as well as we would like, and we're working towards doing better. So, so this is average FEV1 of everybody in the pediatric program, at least 6 to 17. And the national goal is 100% predicted, and the average is about 93% predicted. And you can see that, again, a few years ago, we were down fairly low at 84. We've been making some strides on this, and I'm going to show you a little bit more data on this because really I want to show you where we are after 2014. This ends in 2014. But over the last couple of years, we've been doing better on that, but still have a long ways to go. For BMI, we've been doing okay. Again, the goal is that everybody BMI be at the average at least be 50th percentile. Really, our goal is that everybody's above 50th percentile. That's a real aspiration, but the goal, at least here, is that the average is 50th percentile. That's percentile compared to the non-CF population. Okay, so in other words, there shouldn't be any difference between nutritional measures in children with CF versus those who don't have CF. And again, we've generally been doing pretty well on that. Dropped a little bit in 2013. In 2014, the average was the 53rd percentile, and that puts us a little bit above the average. Now, I think that there are better measures than that. I'm going to show you that in a second. But right now, what I want to show you is data that we've been collecting. Okay. Now, the question though is, so how do you do this? How do you, for example, get better lung disease outcomes in patients with cystic fibrosis? And so this is a part of the discussion. Again, we talk about, well, we have lots of medicines, but how do we really ensure that we're doing it right? And part of this comes out of knowledge about what is being done best at the CF centers with the best outcomes. And then some of this comes out of our discussions amongst our own team of how do we actually put some of these things into operation at our own CF center. Because there's lots of things that are unique about every CF center, including our own, including how you do things. So, basically it's really prescribed chronic. Most of the stuff is going to seem pretty easy and straightforward. It's amazing how hard it can sometimes be. So prescribed chronic treatments that we know are effective to patients who should get them, that's pretty easy, right? Well, when patients have signs or symptoms of pulmonary exacerbation, treat them with antibiotics. Follow up when treatment is done to make sure the treatment works. If treatment doesn't work, try something else. Repeat as necessary. Again, this is extraordinarily simple, but I can also tell you how extraordinarily hard it can be. At least it's demonstrated by what goes on in a lot of places, including a lot of places that I've seen. So it is tricky. And then for nutrition, teach families about high-calorie diets and the importance of good nutrition. Identify patients whose nutrition is becoming suboptimal before it gets too bad, and then you really have to rescue them. Make sure these patients are not malabsorbing fat. Do something to get patients to take in enough calories to gain or maintain weight. And follow up to ensure the treatment works. Again, this stuff doesn't sound too complicated either, but it can be really challenging. And then repeat as necessary. And then the final thing that's probably most important is making sure that this isn't just what we're telling you to do when you come to clinic, but making sure that that the patients and the parents and everybody know that that's what they should do, and empower them to do that. So my favorite kinds of visits are when the patient comes in and says, well, here's what's going on, here's what I think we should do. Because that means that they know. And if they know, then we are way ahead of the game. So those are the tricks to the trade of how you do it. Okay, so now I want to show you what's been going on over the last few years here. So this is graphs. Again, this is the pediatric program. I'm still trying to get the data together on the adult program. I'm a little unclear about a couple of things that we need to talk about. But this is from January 2013 through March 2016. So this is a little bit more current stuff. And what I'm showing you here is a slightly different measure than what you saw from the CF Foundation website. But basically what we're doing here is we're taking everybody in the different age groups that you're going to be seeing here, but all the patients who fit into that group, we looked at their best FEV1 over the previous 12 months, and then we kind of came up with that average. And so if I look at, for example, January 2013, that number is the average of the best FEV1 that all of those patients had over the previous 12 months. So from January 2012 to January 2013, okay? And so when we look at March 2016, then we're saying this is the average of the best FEV1 from March 2015 to March 2016. Okay. So basically what we're looking at here is this is children under 10. So you can see that we started out somewhere around 97, and at this point we're up around 113 over that period of time. This is patients who are 10 to 15, and you can see their lung function is lower, but you can also see that, again, we've experienced some good, steady improvements over these last 3 years. These are patients who are 15 to 21. And again, you can see there's a significant drop that occurs with, these are the teenagers, okay, and the young adults, okay. But again, you can see that we've been showing some steady improvement on that. So if you average everybody all together, and I've expanded my scale here a little bit to show off, but so this is the change for the entire clinic, pediatric clinic, patients between 6 and 21, from 2013 to last month, okay? So I think we've been doing pretty well with that. I think we can still keep on doing better. But I think that, this is what we're trying to do. This ultimately, we can talk all we want about how many visits are you making and how well are we screening, but this is really what the bottom line is. How good is everybody's lung function? So now, Sorry,
I was gonna say,
just
yeah.
somebody raised
Where
their hand.
does Kaleido fall in that calendar?
Well, Kaleido falls in a variety of places because, you know, we were involved in some of the early research studies and then it got released. But the earliest research studies, what, 2013? Earlier than that?
So it's been all along.
Yeah. So, well, it's been, yeah, so.
Phase 3 has probably had the greatest impact.
I'm sorry?
I say with the phase 3s would have had the greatest
Right,
impact.
right. So here in particular, I think the phase 3s were really what we got involved with. And that, yeah, so that's probably this whole time. But again, Kaleido is just the G551D
Yeah.
patients. It's a relatively small percentage. Okay. So now we'll talk about nutrition. So again, same thing, but now we're going to be talking about the best BMI over the previous 12 months. But this first graph is patients under 2. There's a lot of ups and downs here because we don't have a huge number of patients under 2. So it changed a little bit one way or the other is going to be up and down here. But again, what you can see, and we talk about weight for length percentile rather than BMI in the kids under 2. But again, this is what we've been seeing over the last few years, average BMI for the under 2s. This is average BMI for the 2 to 10-year-olds. And again, remember, we started out pretty good to begin with. This is BMI in the 11 to 19-year-olds. So the overall average for everybody looks something like that. But in my opinion, actually, you know, we can keep on driving BMI up and then we just have a bunch of tubby kids, which may not in the long run be in their best interest. So I actually think in terms of nutrition, what we really want to look at is what percentage of our patients are under less than ideal nutritional circumstances. So that's what this is. So this is percentage of patients whose best, and we're going to go through a couple of different measures here, but percentage of patients whose best BMI over the previous 12 months was less than satisfactory. And then we can talk about how we define satisfactory. So clearly, unsatisfactory is less than the 10th percentile for BMI. Okay, and so you can see that, again, we were a little bit less than 10 before, but now we're, you know, we've gotten even lower than that. This is the percentage of patients who've got a BMI less than 25th percentile. And again, this is actually, I'm very happy with this particular number because really that's almost down to as low as what the percentages of patients who are less than the 10th percentile. And then this is the percentage of patients with a BMI less than the 50th percentile. So, so again, you know, we really want everybody to be at or above the 50th percentile, theoretically at least. So we have a little ways to go there. But I think this is showing us that we're, you know, we're getting closer to where we want to be. Okay, and then this is a similar number here for the babies, the weight for length less than 50th percentile. And again, you know, I want to be doing better with that, but we've been you know, doing okay with that as well. Okay, so those are our outcomes. We thank you all from our team. And again, this is all part, we should have pictures of all the patients in here as well, because really ideally, when we talk about the CF team, it's us as caregivers and you all as patients and parents. So thanks, and if you have any questions, I'll be happy to take them. So I think that we were going to take a little break now.
We have,
on the agenda.
No questions, yeah, we'll take a break. If I can ask that sort of the first 4 rows of tables to go and get it to the cafe, and then when you guys get back, that's the last, we'll go get it, and then we'll have a nutrition talk while you're eating. So.
Right. So actually, I just wanted to also take the opportunity, I don't think we've thanked all of the sponsors and the vendors who really have, you know, again, they help us not only to be able to put this on, but some of their financial support also allows us to continue a number of educational sorts of activities that we do all year round. It gives us a little bit of flexibility and discretionary funds to be able to do the things that we need to do for the CF Foundation, patients and for everybody. So again, we thank them, and we would encourage you all to spend a little bit of time talking with them and let them show you what their, what kinds of products are that they're making to help benefit you as patients.
With the
It's so funny.
This is my wife, Mimi. How are you? Yeah, it was nice. Yeah. So much she said. And this guy, how are you? Nice to see you again. How are you? Yeah. Yeah, you're out. You know, everybody's always been on this side. This side.
That's right.
Yeah. Sure. I have beer. Okay.
Where do you want to line up?
Wall? He sounds like a true photographer.
No, because of the way it's done.
So we look at first.
I'm sorry about that. I'm just getting a lot here, so.
All right.
So we're gonna wait all the
Thank you.
Thank you.
Yeah, Dr. Schechter was my son's doctor in Hasbro Children's Hospital.
But he's been so around so many places, Jeff.
Well, I think that.
Make sure you put a GPS sticker. You gotta keep track of.
Well, maybe come to the
Reading with snow in it, and it was so breezy. I
Oh, okay.
I've been in the same room for 27 years, and they were really
Oh, yeah. Absolutely. Healthcare is good.
I'm not ashamed of it. You're looking so interested. Okay, we're in. Now, what are they saying? Yeah. You need to. He needs to check.
Yeah.
The high school center. But the real important thing is
Okay, my pleasure.
She reviewed it.
Okay, good. I remember the special needs press. We can only do that. That we could talk to about.
So you see what I'm talking about, like, you're and I brought my
Big quote. Yeah, thank you. Oh, thank you for your help. Yeah. Thank you. Better because Oh, sure. Absolutely. It's very good experience.
Often than not, in the first question, maybe just appearances.
Well, because then there's no. But then if they stop doing it, you only have like. Because otherwise, then when they're not, they don't want to do something. This, you have to start. And then you have to fight them to not have to play.
I have a 13-year-old.
Sergeant's going to you guys.
I've never heard this. I really enjoyed listening to that from the Boston area. Dr. Shepard used to be Shaz was in Providence. But anyway, I was really excited. Thank you. And I was so excited to do it. Triumphs that we had this year.
And that's why I hate snow.
Okay. My son's 13, and he plays baseball. And he's done very well. This year, one of the biggest things is that I've always told me that clients and difficulties now high school, we got a site and there's a team. You might be interested in just watching this video, but you can watch it first. It's on the page. It's 11. So, it's not sure. So I'm always, but there's
Thank you so much.
it's about two guys. Cycling on bikes. And season of bike racing. Their team is called Racing. And the video on YouTube is called Racing for Free. And it's really great. Yeah, my son started. He's like, I want to join your cycling team and start riding his bike. And so he now actually, they gave him a jersey and all that, and he's doing the road races and all that. But what he does now is he does his nebulizer. A lot of times he'll got a stationary bike, and so he'll do the stationary bike part of his training. And then when he's breathing, you go and then after you get out on the bike, you're able to better. So you have to actually should be so happy. And I one of the other reasons why I want to see thanks for and I just say, I want as many options. Right there. Maybe I have that schedule, whatever it is. And down in Florida, I was out there. Programs, yeah, I get some really interesting things going on. One of them here is patients that this year that just started. But is there a company that is like focusing on, helping adventures and providing these options and parents and so I'm looking at I encourage you to, that's something that maybe be interested in. Yeah, the gentleman who's here is live and so they have training about the uniqueness of all kinds of different types of yeah, I just thought, I'd like to know that there's the best practices. Not just the best machines, but let's do that. What's I also did it. It's also my son is on because our community is disconnected. And I would encourage him to do better with cases. Whatever, you can get there. I want options. Anyway, I hope your child So yeah, that's a lot.
We would never tell you that.
Umbrella. I want to
Did we win something?
Joel took my line about bad hair. But Bob's never had a bad hair day. How are you? How are you doing? I'm good. Looks like the family's doing well. Your daughter's doing oh my God.
I have a son.
Okay, good enough, good enough. How you been? You're okay now?
I don't know.
Let them know there's plenty of food.
I listened to this really nice guy, so you know.
Are you gonna go to the dance and they'll start the next thing? From what I hear, it's the Shermansky brothers for Ellen. Because Ellen and I wrote, I'm like, yes, they're gonna take you out of the theater. Because we were just watching the dance and I thought about
I think I just take one of these.
No, I don't think so. Go down and see your new digs. I remember their building and I didn't realize that it was, I knew it was finished, but I'm sure it's nice, right? It's the Nelson Wood.
There's two separate rooms for doing
Yeah, well, it was well deserved. You guys needed a new A safe trip.
Thank you. Thank you. The weather will be okay.
There's a lot of wind, I don't know that Richmond.
We're not like going through Chicago.
Yeah.
Have you started yet?
All right, we're just gonna go ahead and get started. You guys can continue to eat. There is plenty of food, so if you want to go back for seconds, please feel free. We're gonna talk about healthy family meal planning with cystic fibrosis. I know it comes up quite a bit with families. I'm Rebecca Hall. I'm one of the pediatric dietitians. I've been working in CF for about 3.5 years now. This is Brett.
Hi, I'm Brett Waltney. I'm the adult dietitian. I've actually only been working in cystic fibrosis for almost a year. I'm coming up on a year, so nice to see and meet everybody.
So first of all, we're going to talk about how to add calories and proteins to a family member's diet who has cystic fibrosis, because there's all this talk about obesity and things like that, but yet with our population, we need those extra calories and that extra protein. But again, some siblings don't have it, and some siblings do have CF. So we don't want to make our siblings who don't have CF overweight.
Or the moms.
Or their moms, yes.
Right.
So there's some simple additives that we can add to current foods. Olive oil, avocado oil, canola oils to pastas and things like that. If you look at adding either 1/4 of a cup or 1/2 of a cup, which really may sound like a lot, but it's really not. So you're looking at 1/4 of a cup here and 1/2 of a cup of nuts, seeds, dried fruits. That's going to add extra calories as well. So with the olive oils, you can add those to any kind of pastas, pasta salads, on the pizza. Pizza's already going to be greasy anyways. And then some good things would be like hummus. It's easily spreadable onto a sandwich. So where mom can be eating a plain turkey sandwich with cheese and maybe some light mayonnaise, the CF family member can eat that same sandwich with full fat mayonnaise as well as some hummus or guacamole or avocado onto it. It's going to add more calories in smaller volumes so that they don't get so full so quick. Most of my pediatric families know I preach never eat anything plain with our cystic fibrosis patients. Vegetables, fruits with any kinds of dips, crackers with cheese, crackers with peanut butter, those types of things. Some things that adults may be able to do is, like, if you go to Olive Garden, they have the bread sticks. You can get some Alfredo sauce and dip the breadsticks into Alfredo sauce, which is really good. Speaking from experience, I've done it. There's also like making oil and vinegar based seasoning to dip any kind of bread in, and that adds the calories in smaller volumes. So,
And always bring your enzymes.
Yes, always bring enzymes.
So, everyone thinks popcorn very, light, good calories. Both the whole family can enjoy, just add and drizzle like the olive oil like we were talking about, or extra butter, just making a little extra calories, or, even throwing in some trail mix or, M&Ms or something to kind of make it a fun snack too is a good way to add calories. Like we talked earlier, the guzzling of the sodas, great and all, but try to replace those with a little bit more. So milk, juice, something else a little bit more, nutrient based. Getting calories doesn't just have to be empty. It can actually be good for our bodies as well. Adding like powdered milk to anything and everything. That's a great way to add calories, and it really won't change anything of the food. It will still look the same. It will still taste the same, just as extra calories. I know my adults liked coffee, so I always tell them to do the carnations and breakfast or the powdered milk and the coffees to make it extra calories, because I know they're like, no, I don't want a latte every day, or I get tired of, those drinks from Starbucks. So I tell them to always make it a little bit cheaper too. And again, like we said, adding extra margarine or butter to foods, pastas, mixed vegetables, that's a good way to get in, good calories as well as still being healthy. And again, just like a teaspoon or a tablespoon. It's not much. It's not a lot. can add a lot of calories very quickly too.
Either that, if you don't have measuring spoons, the small spoons in your set are teaspoons, and the bigger ones are tablespoons. So
pretty easy, right? Yeah. We're not doing much. We're not changing much of it.
So again, we don't want those empty calories, but we want those good fats. So a lot of family members are like, well, what can we add and how much do we add? So we went through and we looked at different oils that we could add, peanut butter, little seeds that we could add, and how much you would add and how many calories it provides. So if you're looking at 2 tablespoons worth of peanut butter, that's almost an extra 200 calories. So, and then again, the oils, you're looking at only tablespoons. It's not a whole lot, but yet it adds those extra calories. So how do we incorporate this? We're telling you about how to add calories to the patient with the cystic fibrosis diet, but how does that help the non-cystic fibrosis family members?
And that's how we lead into portion control as the dietitian cap comes on. So I know even in adult world, I have a lot of families. They're like, well, so they have like 6 plates full, and I'm trying to eat mine, and then I have family members are like, why can't I eat that much? And so the big thing is just trying to do portion control. So as you can see, we have a couple of examples up there. Just a plate of spaghetti for you, and then you can kind of add extra CF, or should be a little bit more, and kind of putting the grated cheese on, and kind of making sure they have meatballs, and kind of like doing it up. Not saying that you can't do the same thing, but we just have to be mindful of the portions, because as we would love to have the metabolism, we want to stay healthy as well. So you can see just the difference: 712 calories to 900, just adding an extra few things. We also have another example, just like a sandwich. Like everyone's like, oh, a sandwich. But all those, healthy fats and things we can add onto the sandwich to make the calories just a little bit more. Or adding an extra slice of cheese, or putting more meat, just kind of along those lines, kind of just adding those extra calories. And like we said, versus light mayonnaise versus full fat mayonnaise, or salad dressings, or anything along those lines. So we're not adding much, but it's just how fast the calories can add up.
So another good thing is substituting ingredients. So to add more calories. So for our non-CF family members, we want to have low fat, no fat ranch dressing, mayonnaise, those types of things. But you also want to have that full fat in the refrigerator as well, so that when you are going to grab something to make a sandwich, or the teenager is wanting to go in and get the whole milk, they know that they can grab theirs versus grabbing a family member's. And the same thing as far as cheeses and yogurts and things like that. Make sure that you have both non-fat and full fat for CF and non-CF family members. So here's a couple of more recipes as far as to make a fruit smoothie at home that's high calories. That you're looking at 454 calories versus a low-calorie smoothie that's only 242. It's great for the summertime as far as outside and coming in and playing in the snacks. An egg breakfast wrap. So the top one again is the high calories, looking at about 550 calories versus 276 calories, but yet we're still using some of the same ingredients, just substituting full fat versus low fat.
Okay, so fruits and vegetables. We always want to incorporate, colorful plate, but everyone's always like, well, I don't want to eat the fruits and vegetables because I'm not getting the bang for my buck. So this is just some other, more tips that we can do to kind of incorporate more of the calories into the diet, even though they are the healthier items. So like we said, just to add extra calories, you can add like honey into a bowl with like milk, or yogurt, and do fruit there, and that adds extra calories, and that's a great breakfast too. Kind of breakfast on the go. I know a lot of people are going towards that direction because our daily lives are very busy. So also like Mexican themed meals. I mean, you can do a little bit of anything. You can do tacos, guacamole. You can put carrots and kind of make it up as something a little bit bigger and put celery and corn and everything else. So those are good ones, as well as doing casseroles and dishes. So always incorporate those items, as well as like whipping cream. Those are good ones. Let's see, Nutella is always a good one for everybody. Nutella and like strawberries and things along those lines, as well as caramel and peanut butter, like we've already talked about. And you can easily add those and just add the extra calories on top.
So here's some kind of like high-calorie fruits and vegetables. And then I also wanted to talk about some finger foods, because I've got several families that are transitioning from infants to toddlers and things like that. Again, our fruits that are going to be higher in calories, as far as you've got bananas, plantains, which are going to be, where was that one at? Which are going to be there. And then you have mangoes, which are here, papaya, and avocado. So there is our papaya. Corn, sweet potatoes, white vegetables, artichokes, which are here, peas, parsnips, and yucca. It can be, did I say that right? Okay. Which are here. It's one of those root vegetables that are going to be a lot higher in calories. They can be cooked as far as like making them into a mashed potato and, that type of thing. Finger foods for infants and toddlers who are trying to, transition over. Black beans, edamame, which is that one right there. Dried fruits, as long as you keep a really close eye on and don't give them an entire handful of it, because it could potentially be a choking hazard. You just want to keep an eye on that. Ground meat muffins. They have you can make little individual tins of muffins. Cheese and crackers, peanut butter and crackers, those types of things. Some of these fruits as well can be cut up into smaller pieces to help with finger foods. If you are buying canned foods, buy the ones in light syrup for non-CF patients and in heavy syrup for CF patients, because those are going to, that's going to add extra calories, even though it's, it's soaking in syrup and things like that, it's still going to be that extra calories.
Okay, so we're going to move on to healthy snacks instead of, junk food. Because I know that's another push for even, teenagers, young adults trying to, be like, I want to kind of have some, my own responsibility, as well as my adults that are, going to work and trying to plan food around everything else too. So, trail mixes are a really good one, and you can really spice up the trail mix now. Instead of just doing, nuts and some dried fruit, you can do all sorts of things. You can put chocolate in it, you can kind of make it anything you want. And, I always just go with whatever's on sale that week and do almonds, peanuts, whatever you would like. String cheese, like wrapping it in deli meat. That's a really good one. You can even put some mayonnaise on it, and, you can even put guacamole, hummus, anything along those lines. That's a really easy, quick, healthy snack that even for teenagers or, young adults can do as well. Hummus, we talked a lot about hummus. Hummus and carrots, you can do hummus with pita bread, crackers, anything along those lines really is a great snack, as well as good protein. Popcorn, we like popcorn. So again, we've talked about, drizzling popcorn, adding the trail mix to the popcorn is a good way to add some calories, as well as a good snack. And dried fruit, we're sticking on that as well. And dried fruit's a good one. You can kind of see it's not much, so half a cup, fourth of a cup, and adding lots of calories. So a good snack. And you can do a little bit of anything. And we have some pictures of trail mix and dried fruit. So we get a lot of our stuff from this website. It's called Chef for CF. In your bags, there's a couple of recipes as well, and then we use the CF or CF Foundation. Brett and I both work with cancer patients as well, so we have to help whenever they don't have appetites. Again, that whole same thing as far as higher calories, smaller portions types of things. So we have a little treat for you.
Now, I am proud to say that in this bag, I hold 9,000 calories. Yes.
Oh, I thought you were taking for volunteer.
Would you like to try one? It is a recipe. It's a no-bake peanut butter bar. Rhett and I made it last night and wrapped them up. It is a really good treat. I made them in smaller portions than what they actually say to make. It is peanut butter, honey, oats,
Dried fruit.
and crushed cashews. So,
Oh, it has oatmeal in it too.
yes, everybody. And there's also a hamburger recipe as well as a chicken salad recipe.
Don't be scared, they're not.
It is one bite, but thank you.
What service are we not under calories?
No, so we can make it for the CF patient. I think the bars, it makes out to be 16 servings, and the bars may be like this big, and each bar is 570 calories.
So I'll start the questions. Now, if a child or if an adult has a favorite item that is great for them, after a couple months, they'll get tired of it.
What did you say?
So I'm talking about kids and adults, if they have a favorite item that they just love, and it's got high calories, after a couple months, if you give it to them every day, I've never, just thought of this while you were talking, I've never said, just save it for like once a week or something.
Yeah, so I like to have my patients rotate. So a lot of my patients have certain foods that are favorite foods. And instead of saying, oh, he likes the peanut butter bars today, so let's feed it to him every single day, have a peanut butter bar, a Pediasure maybe that he likes, or an Ensure, or Scandy Shake, and kind of like alternate his favorite foods so that you're not getting tired of those one specific food.
And I know a lot of times when they get to adult world, they're like, if you tell me to eat peanut butter one more time, I'm not going to drink with you. And I'm like, okay. I understand that, so that's fair. So, it doesn't always have to be the couple things. There's always new things out there. Always try something new. You can always add something to a different recipe. And, there's always, I always Google things. I'm like, I only have these 2 ingredients. Should I add something to this for that? That's fine too. So, just, there's plenty of things out there. So even though we've given you great, like 4 or 5 different higher calories, doesn't mean you have to stick with those. You guys can keep, adding and trying new things, and, keep them, interested. Food's gonna be fun. We don't like to pressure food, because then it's gonna be a negative effect.
So there is an adult commenting online saying that they ever become tired of mac and cheese. He adds extra butter and Velveeta cheese in it.
Yeah. So see, by the time they get to me, I'm like, so you've heard everything. So you can always make it fun. It doesn't have to be always those high calories. You can eat the portion size and eat the amount, or try to do small freaking meals and just get the calories that way. So there's always ways that we kind of work around. So I completely agree with the adult patient.
Well, and I just wanted to suggest, I know with children, the veggies, a lot of times you can't get enough veggies in them. So I've done the Scandy Shake, but with ice cube, and put some veggies like spinach or kale, or and a whole banana. So as opposed to, it's kind of sweet, but not very sweet. My daughter didn't like sweet, so if you just do straight Scandy Shake, and the Ensures are also sweet. So trying to get the veggie in this way with a fruit, apple slice and banana, and then some nuts. You could even put nuts in there, and some spinach, and a little Scandy Shake, and let it rip. And then you give them the colorful straws. They have those very colorful straws. So if it's a green drink, you give them a purple straw, or
Yeah, definitely always make food fun. Because if it's not fun and they just see like, oh, I have to eat because this is my health and stuff, you make it fun, then it's not a habit, or like you are always telling them, oh, you have to finish your plate, you have to. So at least it makes it more positive,
Well, plus it tastes berries and you're getting in the veggies that, you know, if you just put a bowl of spinach in front of them, it's not worth it.
Yeah, definitely smoothies are the best way to do it because you can kind of definitely do different recipes and kind of the fun, and you can add, you know, different proteins, and you know, you can do the nuts or you can do the veggies.
And along the lines of saying it's fun, have them in there in the kitchen cooking with you, that type of thing, so that they realize that this isn't only going to be something that's I have to do because mom says, but it's something that whenever I become an adult, I'm still going to have to do it. I'm still going to have to know what I'm doing to keep eating and make sure that we have a long, healthy life, you know.
And we always like to hear, you know, from I always talk to my adult patients, and I'm like, well, tell me some fun recipes that you've been doing, or, you know, talk to me about fun recipes, so I'm not always being like, okay, well, you lost 4 pounds today, so what are we going to do about it? I kind of bring it in the more like, okay, so what have you been doing? What are the new things? And kind of try to be like, oh, well, here, why don't you try adding this and that into the recipe and see if it tastes good, or try it. And so you can always do it that way. So.
How do you, this comes up a lot, somebody mentioned parents before, nobody will ask this question, but how do you advise parents who go to McDonald's and let one child have the shake and the double cheeseburger and the large order of fries and the other one has to get the salad?
So it's one of those, well, I would prefer you be cooking at home, one, because it's going to be healthier, two, it's going to be a whole lot cheaper, but there are ways to, you know, you still want the patient who's getting the double cheeseburger to still have the salad. So, okay, you can have the salad with a creamy dressing on it, as well as the chicken nuggets, and then you can have your, you know, you're still hungry, you can have that hamburger afterwards. And okay, yes, the CF child gets the large shake, but we don't want to make the other child feel like they can't. So instead of getting the large, why don't we get you either the small or the kids shake? So you're still getting the treat, but you're not necessarily excluding them from having that same treat. And again, make it something that is, if we're going to do that, only do it like once a week, so that the other child isn't going towards that obesity aspect, and, you know, it's not an everyday thing.
Yeah, I agree. We're back to the portion control. Yeah, that goes on. So that's a big one. So. And then just staying active. I mean,
make them run around.
Yeah, I mean, that's good for the camper and your other child. So
yeah,
I mean, that's perfect. So just keep them active, and that will be good.
What about kids that want soda? I mean, do you recommend on that?
No, that's soda.
Again, it's one of those, yes, soda's going to provide you those calories, but those are going to be those empty calories. That's going to be where you take them to the dentist and now you've got a cavity because you've been drinking too much soda. I would prefer, if we're going to do it, let's do, you know, like juice. They have some juices now that have more of more calories and more like vegetable servings and fruit servings in them versus just the high C or, you know, regular plain over-the-counter like juice that's high fructose corn syrup, that type of thing. If you can get milk in them, that's going to be a lot better. Milk, a smoothie, those types of things. Something that's not clear, because if it's not clear, then it's got that fat content into it, and that's going to have more calories and more nutrients versus a soda. So it's a matter of, if they're having one every single day, maybe drop it down to every other day, and then slowly dropping it down to maybe once a week type of thing. You don't want to like completely cut it out, because then you're going to have some what?
Mutiny?
Yeah, mutiny is a good word. You're gonna have that mutiny on your hands, but then you want to say, "Hey, let's try this instead for today," and then or cut down the serving size instead of doing a 12-ounce bottle. Okay, you can have a half of a bottle type of thing.
I've got a question. When it comes to school-age children, like ours is 5th grade right now, and he is completely anti-pack lunch. He wants to buy lunch at school. So how do we regulate that he's going to eat what he's supposed to be eating at the school versus what we would pack him?
What you would pack him. So again, I think part of that one is working with the doctoral, you know, the psychology doctoral student as well, as far as they don't want to feel like They are, they're being different.
I want to be normal.
Yeah, I want to be that whole normal aspect.
We can't get him to even touch a PE shake at school. He won't take him to a PE store or a PE store at school.
Won't take him at school?
He won't, he refuses.
Will he do it? Will he do it when he comes home?
And
That type of thing.
And a lot of times my adults, they don't like to bring the inshore because they're like, people question them. Like, why do you drink inshore? Sometimes I'll tell them to put it in a different container and they'll drink that better. Because then it's like, if it's in a water bottle and it looks like it's been covered with like, Crystal Light or something, they're more willing to drink it because that's what normal kids are doing right now. So that's what I tell my adults too, because they're like, I don't want to show people that I'm about to eat like 600 calories in my drink. I'm like, that's fine. Bring one of your tumblers. Who knows what's in? Maybe it's a healthy, smoothie or something. So I try to move that away so they don't have that brand out there.
Again, talking with the school, talking with the teachers, so that they can kind of keep an eye on what's being thrown away versus what he's actually eating. That might help, keeping that open communication with the school to see what's going on, that type of thing. And then talk to him. Okay, you don't want to pack your lunch. Well, let's see what we can't do whenever you get home to make up for something.
Looking at Tyler?
Yes. It's a matter of one of those, just kind of working with him, maybe doing some kind of reward system. Again, that's where the psychology doctoral student comes in and helps. And if you wanted to, next time we could probably come in and sit down and have both of us come in at the same time and see what we can't figure out and see what he's willing to do. He is at that age to kind of determine what he wants to do and how much he wants to eat.
Yeah, and how can you make that meal at school high calorie? There's certainly ways to have a high calorie meal from school lunch, or how to pair things with school lunch. So you're having some school lunch with some snacks from home, kind of a combination type thing.
Well, I know a lot of the standards they have now on the school lunches makes it very difficult for us to get the high calorie stuff in there. And that's what concerns me.
Right.
They're handing you a couple chicken nuggets and then carrots. And that's not good.
Yeah.
Fill the void.
And maybe even
Might be
see,
able to ask for double servings.
Yeah.
Those things can be included on the budget report, with recommendations for accommodations while at school. So those are things that we can write for so that the school addresses those things at school.
Yeah.
or even try to compromise with them, be like, hey, we're gonna do 3 days a week and maybe do 2 days a week, or maybe look ahead. Like, what meals do you want?
Looking at Tyler.
She hasn't been around. You said he's in 5th grade, so I got some years. Got some years.
We'll warn you ahead of time.
One of those, it might be, okay, well, let's do this. Let's buy our lunch, but okay, the lunch is only giving you carrots. So what do you want to eat with your carrots? Do you want to take your ranch dressing to go with your carrots? Do you want to, something that you guys can control as far as putting in and adding those higher calories, so that you're buying your lunch and you have a small packed lunch to get what he needs in. And then that's where that Pediatric comes in. Let's put it into your own thermos so that it's not different and it's not considered a kid drink.
Thank you.
And then you guys have the PowerPoint from today. So there's the PowerPoint in there so you can kind of see, oh, here's, just a tablespoon to just kind of quick reference to.
And we're always available. I'm always, most of the time in clinics on Wednesday, to do that and to sit down and problem solve as far as specific meals, those types of things. Because again, whenever they get to bread, it's, well, we've already tried all of that. We don't like any of that. So we're here to help and try and get it to where it needs. See what we can't do. Thank you.
And one of the things that she mentioned was tell the kids never eat anything plain, but the other way they put it is never eat anything naked. And when I'm, my wife and I are now empty nesters, and when I first heard that, I'm thinking, what's wrong with that? Terry, where's Terry? So Terry's Quinnen's coming up next. So Terry, I could introduce, I could go over what she's done. She's been here for a couple of years, but Terry and I are dear friends, and I get goosebumps because I find myself apologizing for times when I have to turn her down. She knows I'm busy, but she knows, and that's why I appreciate it. She knows that if I can swing it, she can count on me, and that's our best thing. And our second best thing is, so I need to tell this story. I went to Midnight Brewery to have a beer after work, and Terry walks in to ask the guy if he wants to support the Foundation's Finest Brewers Ball. And so we have a beer together, and I'm walking her to her car, and I think as we're embracing at the door, my wife drives up.
True story.
It wasn't, well, so Terry and I are dear friends, and I really, really appreciate the work she's doing with us, and for the kids in Central Virginia.
Thank you. Thank you, Dr. Schmidt, and thanks to VCU for having the foundation represented today and sharing all the great work that's going on at VCU. It really is amazing. Now, I didn't bring any great yummy peanut butter treats, but we do have some great beverage or beer cups, out there. Maybe beverage cups for your high calorie smoothies. So you have to stop out there and check them out. So I see so many people here that are involved with the foundation, a lot of familiar faces, and so glad to see you. And if you're not involved with the foundation, I hope you'll become involved, because we're all here in the same community. Our ultimate goal is to help those living with CF live healthier, better lives, and really the ultimate thing is to find the cure for CF. So I'll just talk really briefly, because the amazing Dr. Bell, I think, is right after me, and he can tell you everything. He has a wealth of knowledge, so brilliant. And the key to why the foundation has been as successful as it is today. So I'll just hit on a few high points about the foundation and what we're doing now with our new strategic plan. So there is a PowerPoint, but I just hit, just 3 little slides. So I was just going to put up our logo and then our mission. So many of you may know that the foundation was founded 60 years ago by parents just like you. At that time, little was known about CF, and there were no dedicated CF care centers, no specialized CF therapies, and little research in CF. And we know what the life expectancy was then. It was very short. With those remarkable families 60 years ago, the CF Foundation has turned into one of the most amazing and inspiring stories in medicine today. And so I was going to sit here and show you what our, that's okay, no worries. No worries.
Go ahead, you give it, and I can drag it on.
That would be fun. That would be the most interesting presentation ever. So we recently changed our mission statement, and I was going to read it to you here, and I should have it memorized, but I did not. So basically, when we changed our mission statement, we envisioned the world where no one suffers from the effects of cystic fibrosis.
You are not going to show me up, are you?
I am. Yeah. It really is a little, just
It was high. It was not there a second ago.
So do I just hit next?
Yeah. Or you can.
Hey, there's our mission statement. So there's the mission statement: to cure cystic fibrosis and to provide all people with the disease the opportunity to lead full, productive lives by funding research and drug development, promoting individualized treatment, and ensuring access to high-quality, specialized care. So the key there is all people. So to accomplish our mission, we are exploring exciting new opportunities that could eventually lead to a one-time cure, regardless of an individual's CF mutation or mutations. But to realize our vision, we must both invest in finding a cure that works for all people with CF, while also addressing the challenges faced by people living with CF today. We are moving currently from being an organization centered primarily on 2 areas, research and care, to one also committed to helping people with CF manage all aspects of their disease in their day-to-day lives. Years ago, we built a care center network to provide comprehensive specialized CF care,
And after we understood the disease, we funded efforts to invest in new technologies to further advance drug development. And as a result, we achieved life-saving results for some people living with CF. Remember, our mission statement here is we want to cure CF for all people. We are going to continue our historic efforts and take responsible and bold risks. And we now have the opportunity to marshal our resources to move our mission forward. So I want to just basically go over our strategic plan. We're focusing on 4 distinct areas on where we want to go. So we're calling it our 4 pillars. Number 1 is advancing research to find new treatments and a cure. The second one, improving and advancing high quality specialized care. The third, ensuring that patients have access to care. And number 4, engaging and enabling people with CF to lead full and productive lives. As with all that we do, people with CF and their families are the focus of every one of these strategic goals. Every decision that the foundation makes going forward will be based on how it will benefit patients and families. So just really quickly, I'm going to go over the pillars. And first, I'm going to look at research. And so we're fueling CF science and drug development continues to be at the heart of our mission and the core focus of our work, encompassing more than 2/3 of our program spending. We have tremendous scientific and technical momentum that is bringing forward new treatments for CF faster than ever before. In 2015, we had the largest medical budget in our history of the foundation and will continue to grow in 2016. This is great news. We are funding more individual research, grants, academic consortia, and industry projects now more than ever. Our research budget is spread across 3 major areas of focus: advancing CFTR modulators, continuing to develop better symptomatic therapies to support CF patients as they continue to age and experience ever-growing challenges, and investing in cutting-edge science that may ultimately lead to a one-time cure. So, going over to pillar 2 with care. Of course, with longer lives come complex new challenges for people with CF, and we are committed to helping to find the best solutions to them. So I'm going to talk about our care center network. Our national network is now made up of 120 accredited CF care centers, including 107 programs for treating adults. In 2016, we are doubling our care center operational grants. In part because of the foundation's efforts, newborn screening is now in place in all 50 states and the District of Columbia. Early diagnosis, as a lot of you all know here, has transformed how care teams can work with families to help children with CF get off to the best start in life. So we're working hard to get these treatments into people's hands as early as possible. So health and well-being is part of this care. In addition, we are making targeted investments in other strategic areas of care, including mental health and emotional wellness initiatives. We've been talking about that a bit. A committee made up of care center personnel, CF adults and parents, and other stakeholders are working to develop the care model of the future. This group is exploring new ways of improving care through things like having a pharmacist at each care center, or making telemedicine components available for patients so that they can visit with their patients via video conferencing. That'd be pretty cool. That's really great for those people who live so far away from the care center. So our third pillar, access. We continue to focus on improving access to medications and new therapies for all people with CF, fighting both at the state and federal levels for coverage of CF therapies and for care at our care centers. Our policy and advocacy teams, together with volunteers across the country, will continue to engage state and national elected officials and other government agencies on issues important to the CF community, including access to specialized treatments and care at our accredited care centers. So with that, I think Beth referenced COMPASS, what used to be known as our Patient Assistant Resource Center. And through our COMPASS program, we are expanding our patient assistance services to help patients receive their insurance benefits and to help care centers navigate reimbursement procedures. So complicated. And we are significantly increasing funding to help patients with co-pays and other financial issues related to CF care. And last but not least, our fourth pillar. The fourth strategic area is dedicated to engaging and empowering people with CF and ensuring that they are able to lead full and healthy lives. We are building a new department within the organization to help us innovate and expand these offerings for patients. In 2014, we formed an adult advisory council, which is giving voice to patients' needs and concerns, and it is now the backbone of our everyday work. Also this year, we are piloting a peer mentoring program, and in September, we're proud to announce we are launching our first ever CF Adult virtual conference. It's going to be quite grand. So as you can tell, there's a lot of momentum, and we're really pursuing some bold avenues in advancing toward a cure for CF. We're inspired every day by you all, by patients with CF, people with CF. So thank you so much. And, let's stay together, and we'll be a strong community, and we'll cross this finish line together. So thank you, guys.
What can I say about Bob?
Be careful.
He's got a good haircut today. So every year at the CF conference, we kind of troll for possible speakers for our Family Education Day. I thought of, Bob's retiring. I'll get that semi-retiring. Bob's retiring, and maybe he'll want to go on sort of a victory tour. So I went up to Preston Campbell, and before I got my idea totally out, his eyes lit up. He grabbed my arm and he said, I've been just looking for a way to get him out of the office. and he said, I'm sure Mimi's going to want a way to get him out of the house. But Mimi came with him today. And she admits that this is her favorite thing. These Family Education Days are the favorite thing for her to do. Bob, he started at the foundation in 1980. Many people don't know that. Michael didn't know that. That before that, he was at NIH before that. But before that, he was on a medical school faculty in the dentistry department. Right? So he started as sort of a dentist. He's not a dental school. Get free dentists. He went to dental school.
Yeah, that's true.
So he's a nuclear physicist. No, you're a physiologist by your PhD training. So after Bowling Green, where he was the physiologist for a dental school, he went to NIH, where he ran many of the projects that NIH was doing in cystic fibrosis, and then started at the foundation as one of the vice presidents of medical affairs. Did I get that right?
There was only one of us then.
Yeah, he was the vice president of medical. He was right, the only vice president. And then after 14 years, he became the president and CEO, starting in 94.
You've done a real good job
so far. I didn't look at these yet. And yes, after many years, he retired December 31st of this last year, handing over the reins to Preston Campbell. We're under good leadership. But Bob will be the first one to stop me to say this is not his doing, the success that CF has had. And the success is palpable. And we are certainly proud of the work that's being done, but the director of NIH quoting him says CF is the most exciting medical story, most exciting story in medicine today, and that's largely because of Bob. And Bob will say, getting back to what I was saying, that it's not him, that it's because he surrounded himself with good people. And I'm here to say that good people want to work with Bob. And you can ask Mimi that question, and you can ask anybody who's worked with him. So it's not Bob taking credit for some that other people did, but Bob really started this. And as he retires, there's been quotes like, most innovative, bold, ambitious plan, pioneering. Beth said honorable, and let me just, that can be, bold. Somebody, you're going to be able to step on.
That'll be good.
Bold could mean moving the water cooler from next to the bathrooms to next to the elevators. I'm talking bold here, and I actually found this news release. Dateline, Bethesda, Maryland, May 31st, 2000. The largest contract ever awarded by the Voluntary Health Organization for Drug Discovery was announced today by the Cystic Fibrosis Foundation. $30 million to Aurora Biosciences in San Diego, California. $30 million. Under terms of this 5-year agreement, Aurora will identify and develop 2 to 3 new CF drug candidates ready for the preclinical and clinical research stages. The CF Foundation will pay approximately $30 million for Aurora, including research supported
early milestones. With completion of the specific clinical milestones, we'll skip ahead, the total will be about $46.9 million. Does anybody know of Aurora Biosciences? Did we just waste $49 million? No. Aurora Biosciences is now Vertex. Those three chemicals are Vertex 770, 661, and 809. Yes, Bob Bell.
I just put Beth on a plane.
And I can tell you that, and Bob probably heard some of this, it was probably difficult to be Bob Bell for a little bit there. There were CF patients, there were parents who were saying, $30 million, really? I mean, you're putting all your eggs in one basket, Bob. What are you doing? What are you doing? I find myself defending myself to many an adult CF going, that's a lot of money. I mean, we've walked many great strides, we've walked many things for him to spend $40 million. Well, Bob will quote Andrew Carnegie, who said, a wise man puts all his eggs in one basket and watches that basket. So,
okay.
Thank you.
Thank you
personally. Thank you.
You know, my business model is you miss 100% of the shots you don't take. Actually, we took quite a few shots over the years, and you know what I'm seeing here is this program here. I didn't bring it up here, but you know, to see today that we have Gilead sponsorship, Vertex sponsorship, Novartis sponsorship of this meeting. I mean, those were names that were never heard of in the CF community until the last few years. And I know I'm going to forget somebody and in this process, Kaizi here and others. But you know, we got a great thing. But I have a suggestion for this meeting next time. First of all, you put me last, and everything I was going to say has already been said. The worst problem is, why do you serve lunch with potato chips, candy? I mean, look in my pocket here. I've got, what is it, Twix in my pocket. You know, and have all that. And then I sit next to a nutritionist back there who's got this big brownie and potato chips, but she is drinking Coke Zero. Okay? So congratulations. You know, it's just, oh, here comes the other one. What are you drinking? What are you drinking? Water. Okay. You need to talk to your partner over there. You talk about empty calories? Oh, she's zero. Okay. Anyway, just don't do that when you try to eat a sandwich back here and you have a nutritionist talking. The only thing I could imagine, you all will meet my wife, Mimi. We've been married for almost 50 years. But I could not imagine being married to a nutritionist. Can you imagine, as married to a nutritionist, everything you take? But anyway, I'm really glad to be here, and I really appreciate it. And one of the things I'm particularly enjoying is I was down here a number of years ago, where we were trying 2011, 2012, before Kaleido, and to see what has happened to this program in the last 5 to 6 years is just amazing. Obviously, the addition of Mike Schechter to the program. Obviously, Joel's been a good friend since he was in Bethesda, almost a neighbor in Bethesda, when he was at Navy and was on our center committee. But now you have a great adult program, and to see the full team that you have a therapeutics development program, you've always had a care program here. All of those things are just so exciting to watch, and I congratulate the leadership. But the other thing you should have heard, and I know Terry will want me to say this, is if you listen to Dr. Schechter this morning, everything was mentioned, CF Foundation, CF Foundation, CF Foundation, CF Foundation. That's where, you know, this is what we've helped to create over time. And, you know, I was with another foundation yesterday, I won't tell you who they are, but boy, are we the envy of every voluntary health organization in the country, of what we've been able to do, what we've been able to do for our patients. When you're talking about a median life expectancy of 41 years of age, I mean, that's still obscene, okay? I'm not here bragging about that. But I can remember Doris Tolson, who founded the foundation, was 5 years of age when her daughter was born. In 1955, her daughter's now 62 years old and a grandmother, making Doris Tolson, who is now 80-some years old. She wouldn't like me to tell you what her real age is, but she's a great-grandmother. And
That's how it's happened. And to think that last year, for the first time, over 50% of our patients are over 18 years of age. Again, it's still an obscenity that it's not more. So that's why I titled my presentation, Can We Do Better? And now that everything's been presented, thank you very much. I did tell you right now, we can do better. And so, but look, and the other thing I like about here is the audio visuals in this room are so bad. You can't read anything. So from the fourth row back, okay?
And so advanced that when somebody stole them a USB drive, they have to go arrow over.
Oh, okay. Well, I'll try. What about the thing that points up here?
Yeah, you can use Michael's pen.
Oh, is this Michael's? Oh my God. Okay.
You can just shoot yourself in the eye.
What's your Oh, I got it here. Okay. Okay, I'll leave my tricks here for a reward. Is that okay? Rewards? You know, like yours? So anyway, let me talk here a little bit. Where are we today in cystic fibrosis? And where do we want to go? Terry talked about we're moving toward a one-time cure. And this is really over at this end where we talk about gene and DNA and how we might get. Here's where we were until 2012 when we got the production of approval of Kalydeco. We had daily therapies that were treating the symptoms of cystic fibrosis. And that's still the mainstay of what we do, because that really, all patients have to benefit from those kinds of therapies. And so, you know, we talk about how do we treat infection, how do we get rid of the secretions, how do we deal with inflammation, nutrition, things that we've already talked about today. And so, you know, you hear about Kalydeco, you hear about maybe gene editing and things like that, but the fact is that's still the mainstay of what the physicians have in their little black bag, except for Kalydeco and Orkambi, but we still have to continue to improve on that. So I got to figure out which is, oh, there we go, let me go. And we have an amazing pipeline that hopefully you could read this one better than you could Dr. Schechter's. We have an amazing pipeline, not just talking about up here at the top, but we're talking about new antibiotics that we have. You know, we have a number of new antibiotics and approaches to use antibiotics. We have antibiotics in development for MRSA and things like that, and new approaches, because we're going to constantly have to do this until we really get to those one-time cures. And so that's a very important part of our pipeline. And don't think we're neglecting it. This is probably as big as we've ever seen before. We're still dealing with nutritional. We're talking about a new pancreolipase that we're coming out, new anti-inflammatories that we're looking at in terms of taking care of this inflammatory response that we see in the CF patients. So I want to assure you that we continue to make that those approaches, and we continue to add to that pipeline every single week as we move forward in our efforts. So let me go back to that. So again, these are new therapies to benefit all people with CF. So I'm not going to go through all of these. I've talked about the anti-inflammatory mucolytics. We're looking at new mucolytics. But I really want to encourage you, something Dr. Schechter said earlier, go to the website. Because now that website is very proactive. You hit it, you can see where the studies are being done, you can see who's manufactured, where the clinical trials are being done, and everything, because it really ties into NIH.org Clinical Trials Network. So I really encourage you to do that. And that was one way I can briefly go through a slide.
And if we're not doing that study here, we can send you somewhere where they will pay your travel.
Absolutely. And there's places around here because everything is pretty close. Whether you go up to Washington, where you go, Charlottesville, wherever you go, there's opportunities to go forward. So this is really where we are today. But there's another component that really comes through here, and we've discussed it. So it's going to let me go through this very quickly, because I said I was the last one at the end of the day, and it's already been discussed. But let me go through this one. It is our care center network. There is nothing like this network in the world. And this was actually started in 1965, the same time we started our patient registry. This is our care center network. And I tell you, there's so much standardization in CF care across this country that make us sort of the envy of the world. And that standardization has been determined by the best physicians that we can bring together by consensus. We're using consensus conferences. And so this accreditation process, now we put out, just for the core component of these centers, about $17 million a year. But when you get to talk about some of these being a subset of our therapeutics development work that we added, now pharmacists we're adding to these programs, adding some mental health workers to these programs, you can see that is clearly over $30 million a year that we add to that. That's what you do when you invest in the cystic fibrosis. Is that what I was supposed to say, Terry? Yeah. Okay, thank you. Just wanted to make sure. So, but this is another thing. There is no health without mental health. And Dr. Schechter talked about this earlier. And this is something I think we're very excited about. And I really came down here and I didn't know that Mike was going to be talking in front of me to congratulate you all on receiving one of these awards. I think this is great that you're going to be able to have a mental health specialist, because he didn't show this data, but I'll show the data, but he would help to derive some of the data, is the fact that the incidence of depression in cystic fibrosis in terms of the caregivers and the patients is about 2 or 3 times higher than a community prevalence for our community. So it's a big problem. It is a big problem, and that has such an impact on the care and ultimately the care. So when we say there is no care without mental health care, I think, or no health without mental health, I think that's another innovation from the cystic fibrosis. And I'm not going to, that was going to this time call upon people here and say, come up and talk about what you're doing mental health, but you've already heard about it. So is there anything we need to add to that? You've been doing it for a long time.
Yeah, and I am proud that we've been able to do some of this. And I'm back on the center committee as a site visitor. And I've taken our idea to Memphis and to Worcester and to other places, and they go, wow, why didn't we think of that? And it's the getting some help for the patient, for the centers that really can't afford hiring a psychologist or a psychiatrist. It's going to be great.
So it's a small center here, but boy, I tell you, the vitality here in terms of innovation, everybody's, and I was so delighted to see what's happened to it. So anyway, we're going to have a mental health coordinator, provide direct care in train for, if trained in psychotherapy, lots of different things are going to happen in that arena. So that's another innovation. So, okay, so we're taking care of this end of things, okay? And we got programs in adherence and things like that that are moving forward. But what we've really been excited about the last couple of years, it really started out with our Aurora bioscientists and Vertex, is we really are starting to treat the basic defect. You know, we've treated the symptoms, we've treated the thick tenacious secretions, we've treated the infections and so forth. But that's a daily therapy, and we're still dealing with daily therapies right now. But this was our venture back in 1999 when we started this, and I was 6'5". I had a head of hair. I did have bad hair, but that's not a problem anymore. But when you make a commitment of $40 million to something, and we didn't know until 2010 that it seemed like it was working, you have a few sleepless nights over that. But fortunately, Bill and Melinda Gates gave us $20 million, and we had developed Toby, by the way. CFF developed Toby. We licensed it to Pathogenesis, and quite frankly, we put in another $20 million in the bank, so we paid our own way to do it, and we didn't have to take away from our center programs and our basic research programs. Anyway, this is where we are, and I will tell you, this was one of the happiest days of my life when in 2012, this is about 3 months before she was taking Kalydeco, and here is Eliza here with the little blue pill. And this is the blue pill I always refer to for cystic fibrosis, not the other blue pill. But anyway, here she is, a few months after taking Kalydeco. She was obviously G551D. And I tell you, that was an amazing proof of concept. I was given a presentation a couple of weeks ago, and I said the most important proof of concepts we've ever had in cystic fibrosis was when we figured out that chloride didn't get out of the airway cells, we discovered the CF gene, and this time when we showed that Kalydeco, an oral drug, could open up these defective channels. That was a very important observation, because that was the first time that an oral drug was able to effectively treat the basic defect in a genetic disease. You have oral drugs to treat the symptoms of it, but this was the first time in history. People thought we were crazy when we started this process. So anyway, and you know what was so profound about this, and this is data that maybe you can read the axis here, but the most important thing is this was the placebo group, and they started taking ivacaftor G551D, and within 2 weeks they saw a very significant impact on lung function. This shows about 10% of the improvement here, and but you know, the amazing thing is that these patients, once they went on ivacaftor, they had an improvement. But the most important thing is, if I had a longer slide in here, or more up-to-date slide in here, you would see that this would go out a long period of time. Just as a deep, the most important thing I think about ivacaftor and probably Orkambi, we still have waiting for the data, is that the rate of decline that you see in all CF patients is reduced. Generally, if you looked at a CF patient from birth to whenever you took it if there was a demise, you'd see about a 2% loss per year in those patients' lung function. They go up and down, but on average, this cuts that reintroduction by about 90%. So that extends their lives. That extends their lives. And not only having a quality of life improvement with lung function going up, and as you see with the next slide, you know, the time to the first pulmonary exacerbation, they have less exacerbations. Their pH of their GI tract is improving. Their lung function is improving. We've seen eradication of Pseudomonas in some of these patients. This is an amazing drug of what it's going to do. But you know, I'm going to show you in a little bit, we can do better. We're going to make better Kalydecos. We're going to make, and as Terry mentioned, we're not going to stop till we get something for all patients with cystic fibrosis. So, and that's just some of the examples of what's taking place. But if you really looked at this, this is kind of a rough sketch here. You know, right now, you know, if this is one of the slides we use, and this is just delta 508. But if you look at, if you can reduce the slope, the rate of decline here, as we're doing with G551D patients, you're talking about being able, I want to go back, to extend the lives of individuals with cystic fibrosis way into the 60s to 70s. Okay, that's what we want to go. This is a, you know, a schematic, but this was something that one of my colleagues, Dr. Boyle, did. So we're to that rate, changing that rate of decline, you're literally doubling, potentially doubling the life expectancy of some of these CF patients. So that was an important concept. An oral drug, that blue pill. And so, you know, we were particularly excited a few years later, June 24, 2014, when we started to see some data from the combination of that blue pill, and it used to be a white pill, and it was something called Orkambi. In the most common mutation, patients with the 2 copies of the delta 508 mutation. And again, what a milestone day for us. Not as profound, because you're dealing with a much more complex biological problem in terms of what's happening, much more complex. But the fact is, we did see a significant improvement in lung function in those patients. And we're still waiting to determine what the long-term impact is going to be on the slope. But there is, and I'm going to ask Dr. Schmidt here in a minute, Joel, and about their experiences with these drugs. But you know, it was a really good day for our patients, because therefore we've added another 50% of patients that their disease could be modified by the use of oral drugs. And this would never have happened were it not for the $40 million, eventually $75 million, and now over $125 million that has been committed to do this. So that's why we need to be proud. You need to be proud, because those dollars were raised not just by a nice grant from the folks at Bill and Melinda Gates Foundation. And in fact, we monetized another drug, but it was dollars raised by you and the team here, great walks, and the great staff we have had here in Richmond working together with people across this country. So you need to be proud of what's happened there. So this is showing, you saw the last one was about 8 to 10%. This was about 2 to 3%. So, but you did see a change in 2 weeks. That was probably the first time it was measured. There's a young man that's graduating from medical school this year, said he felt it in a day. And he's graduating from medical school in Dayton this year, a good friend, and he was on G551D. And some of the patients felt, could be placebo, but fact is, when you take a whole population, you're seeing this kind of improvement. Not as dramatic at this point, but I can tell you, we can do better. And we're seeing, and clinical trials are going to start this year on a 3-drug combination. Not just Kalydeco and what we then called Lumacaftor, equal Orkambi, but it's a 3-drug cocktail, and this drug is going to go into clinical trials before the end of the year by Vertex. Also, we paid $25 million to accelerate the development of this drug and of the 3-drug combination. And this is some test tube data. If you were to take an untreated person, individual with cystic with G551D and give them Kalydeco, you get up to about 50% of CFTR activity. And this is what we're really trying to see. In 809 plus Kalydeco, you don't get as much. You have VX809 plus Kalydeco in the patients that would be down here. You're seeing that you get 809 alone doesn't do that much. Kalydeco, you see what you get here. But if you take VX809, Kalydeco, and a second corrector, you can see where in the test tube, we're getting very, very significant responses. Responses that are greater than what you see with Kalydeco alone in the G551D patients. So that's encouraging. You got to feel good about that because that's targeted. And now we've got, I'll show you in a couple slides, we've got AbbVie looking at this. AbbVie's here today. We've got Vertex looking at other compounds, 661. You saw some slides earlier that are even better drugs than the 809. So it's nice to have competition. We got Genzyme. I was with the folks at Pfizer yesterday, and a lot of people, there's a lot of competition. It was an amazing proof of concept, and it opened up the space for us. I'm going to start grabbing this thing here. But when I sit next to a nutritionist who's eating the biggest brownie I've ever seen, I'm not going to feel bad about my drink.
That's why we hired.
Yeah, to make you happy. Anyway, these are some. So people are going to say what about the heterozygotes? What about the heterozygotes? Patients with one copy of 508 and another different mutation. Those trials are underway. Are you doing the heterozygotes?
107.
Huh?
107.
Okay, you're doing this trial here. Okay, this one here,
Yeah.
right here. So those studies are underway, and there's different kinds of those studies. About 5 or 7 different studies on the heterozygotes. Using another 661 is a substitute for 809. It's a better corrector, we want to say. Okay, that second compound. 661 is better than 809. Remember, Orkambi is 809 plus Kalydeco, or Lumacaftor plus Kalydeco, whatever you want to call it. 661, you take out the Lumacaftor, you put in VX809, and you put in 661. It's a better drug. It's got a better sense of metabolism. And we think if there's a chance it's going to work in the heterozygotes, that's going to do it. It's not enough. It's not going to work enough, I'm pretty sure to say, of just Orkambi in the heterozygotes. We need more potency here. And I think that's what 661 is going to do, or the 2-drug compound, a 3-drug compound that I talked about. But again, the nice thing about it, we've got a lot of people involved in in some of these studies. Novartis, Bayer, I'm going to talk about ProQR. PTC 124 is working for one of the X mutations. People have heard about the stop mutations. This is a rare group, about 3 to 5% of the patients. This trial is underway. It's the trial that had been approved, had been looked at by the FDA, but they found that the drug, PTC 124, competed with tobramycin. So the patients had to go off of Toby for this. So, and then the second generation, we talked about 2 correctors here, Galapagos, which is AbbVie program here. So I hope you're encouraged by this. You know, we haven't stopped. We're making better compounds, and we're expanding that pipeline to all patients with cystic fibrosis. And I think that's what's really stated in the mission statement. So you want to make any comment on that, please, Joel? How you all using the compounds and here for the disease modifier compounds?
I do, and only because you warned me that I wanted to say something, but
no, that's why I put the slide in.
So, and one of the reasons why he's asking me is because I emailed him a note one time, and I'm not the kind of person that emails him saying, "Dear Bob, what the hell were you thinking?" But 2 patients. One, I remember calling them into my office, not the exam room, to have the parents sit down, and they were staring at me like, "What?" But if you open up your folders, take out everything on the left side of the folder, you'll see a picture of a patient that Children's Hospital is quite proud of, and that's Addie. And Addie had G551D. And she was like 18 months old at the time, and I called the parents in, and I want to let them know that Dr. Bob Bell has found something that might help their daughter. And you can just see the tears welling up. And we were able to get her the drug when she was 5 before it was actually approved, and she's doing great. And that really made me, so that just made our hearts jump. And the second one, we had a patient with dual G551D, and I wrote Bob because we started her on the medicine, like I think the medicine got available, announced January 31st, and we started her on like February 2nd or something like that. And a month later, she came back to clinic. She went to the PFT lab. Her lung function, the best we could get after numerous admissions, maybe 2 or 3 a year, was up to 50% of expected. Jim stares at the screen, he starts crying. Mom stares at the screen, she starts crying. I'm in the background, I'm just dumb, like typical.
Did you have your clothes on?
I did. Did I say that out loud before?
You did. And I'm not going to let you forget it.
And the patient was going, what? Her lung function was 80% of expected. I think 78 or something. And I wrote Bob, and I titled it, I said, "Sorry to bother you. You may not even see this email. I'm sure you get dozens a day, but subject was best day in CF clinic ever." And those are kind of experiences we're seeing here.
So what are you seeing with Orkambi?
Yeah, and with that, we have to temper expectations because Orkambi is a harder animal and harder nut to crack. The science is that in G551D, the protein's already at the cell wall. All we have to do is open it. In Orkambi, we got to get the protein to the cell wall. We got to get an unstable protein to stay in the cell wall and open it. And we still have hope. This is science that we've proven works, and some of the preclinical data we've seen is very promising. And right now with Orkambi, what we're telling to expect is you're not going to feel it. You're going to see less admissions. We're going to see your lung function not declining. I mean, yes, week to week, day to day, every 3 months, it may go up and down, and we may not see big weight gains, but we're going to hold you there until we get something better.
And I want to assure you that something better is in the pipeline. I mean, that's what I tried to show you there. And I think that's what you're seeing. There's about a third of the patients who have an amazing response to it. About a third of the patients kind of hold your own. And there's about a third of the patients who just can't take it. They just, and some of the, physicians are saying, and the physician, I think many of them, or most of them are correct in thinking about this, is that do you really want to put a patient on a drug potentially for a lifetime where you only see an incremental effect. So, so some go on and some come right off in the process. So anyway,
Oh, and I keep forgetting to say, I have to excuse myself because right after this meeting, and my wife is picking me up probably before the meeting ends, we're headed to San Antonio for the TDN meeting. So
good.
I'm gonna step
Look
up.
at that. Look at that. We planned this meeting, didn't we? Except the nutritionist for lunch. Anyway, this is our clinical trial
I
network.
did not plan the lunch.
This is the clinical trial network that you have. They're going to the TDN meeting as we speak. There is no other organization that has this. This is a clinical trial network. What time are you leaving?
As soon as my wife, I told her 2 o'clock.
I'll be
expecting 2:15.
before that. Anyway, this is our clinical trial network. We have about 50 employees in Seattle. We started out with 8 of these sites back in 1999. We're now up to 81, I think I just heard the number for. But what we do here, this is to accelerate clinical trials. Companies come to CF Foundation, and if they got a new compound, that's great. But they can't do the clinical trials efficiently and effectively, they're going to go somewhere else. The group I was with yesterday, they don't have a clinical trial network, and more companies come in the door and walk out of the door. And then we have the patient registry that Mike talked about earlier, which has the natural history of this disease. So congratulations on the work that you're all doing down. It's a great opportunity for the patients. So, but I got to really talk because I see the RC here and got our button on, I think. I am the key. Each of you are really important for getting the clinical trials done. And we provide support for the research coordinators. The PIs, the physicians, they're pretty, they're less important in this process than a research coordinator.
Here.
Yes. She does the recruitment, make sure the trial gets done, and the PIs are down playing golf on Wednesday afternoon. So anyway, I don't believe that's happening down here. But it's really, really important that you are the key to getting any of these studies done. And that's really, I've heard a number that 80% of the trials in the United States that have started, this is in academics and in industry combined, are not completed because of patient recruitment. Is that a number have you heard that number?
I haven't heard that number, but it is certainly something I think every research coordinator struggles with.
Okay, well, we won't have to. So anyway, I want to just convince you that we are doing better. We continue to develop new symptomatic therapies, new antibiotics. We are treating the whole person, improving today's. That's mental health. That's lots of different things that we're doing. We are excited about the first generation of drugs treating the basic defect. We're adding tomorrow's by expanding these disease-modifying drugs to all patients, not just G551D, down to single copies of Delta 508 or double copies, but the X mutations, and we have lots of partners in this effort. And again, but really what I said, and I don't know why we're going backwards here, we want to move to 1 day or one-time cures for CF. So how do we do this? These are done every day. These are done every day. Are there ways that we can start to think about once every 2 or 3 weeks, once a month therapies, maybe aerosolized therapies? And I did a presentation a couple of weeks ago for a company called ProQR. And it's a drug that would be given probably nebulized once every 2 weeks, maybe once a month, and maybe even with the subsequent improvements in it that would need to do. So remember in biology, DNA produces messenger RNA. If the DNA, which has the mutation, I'm going to show you here in the next step. DNA produces messenger RNA in normal individuals that allows chloride to exit the cell. Okay? In cystic fibrosis, you got bad DNA that produces an abnormal messenger RNA that closes up the chloride channel. The disease-modifying drugs are working, obviously, to get the protein up here, but if it's produced, and then obviously to open it. But what we want to do is, can we get normal protein to be produced? This is a mutated protein right here. The channels don't open. And what this technology is is that they are able to aerosolize something called QRO10. And it really kind of reads through, allows for the read-through of this abnormal gene here, or abnormal messenger RNA. And then it produces a normal protein that opens up the chloride channel. It's amazing. And then this is, it's amazing. And this compound was actually licensed out of MIT by a father of a child with cystic fibrosis. And they went out and have raised and talked about the interest in cystic fibrosis, $189 million of money and we supported it very early in the process. But venture capital, not just venture capital, but stock buyers and companies bought it because this is such an exciting technology. And I will tell you, it's now moving in, it's now in safety studies in CF patients. And I won't bother you with showing it to you in a mouse, but I will tell you in a mouse CF where there wasn't with Q10, this is a normal mouse. This is a pre-treatment mouse in terms of saliva secretion. It normalized some of the components that were very important. This is nebulized into the mouse. Can you imagine nebulizing something into a mouse? But this was important proof of concept, and this was what led investors to invest in $189 million. And the founder of Genzyme, who is one of the most important biotech companies, who's one of our partners, and retired, is the main investor in this. So he's a guy that makes things happen. So I'm not going to go into this, but I just want to point to you that this trial is going on. And this is mutation specific, has to be produced for a Delta 508. But one of our partners here is actually, this is called RNA editing. There's another group called RNA replacement, the company doing that, Shire Pharmaceutical, one of the world's biggest pharmaceutical companies, it's offshore in Ireland, but they are doing it for putting normal messenger RNA into the cells of CF patients. So that would be mutation agnostic. No, it wouldn't be just made for Delta 508 or G551D, it would be corrected for all mutations. So that would be something, and that could be given probably once every month or two for the CF patients. So let's go to the next one here that we have here. So we're really investing in this technology to move that spectrum all the way over to the one-day therapies. And here's some of the programs that we just had. We had a workshop last year. We've had workshops. We're investing hundreds of millions of dollars into that effort to move from, obviously we got the one-day therapies to treat the symptoms of CF, the current complications. We're going to continue with the small molecules. Now we're going to potentially 1 week, 2 week therapies, and potentially 1 month therapies. But are there ways that we can start to think about one-time therapies? Could we get into the cell lines of individuals with cystic fibrosis? In our lungs, we have many, many different kinds of cells. Could we take out the cells that are called the progenitor cells? Take them out and correct them and put them back in. This is not unheard of. This is happening in oncology and cardiovascular disease already today. And we are making, and here's just some of our partners that are moving forward in these kinds of areas. Shire, ProQR, Spirix, Parion Sciences has got a drug that works in addition to, it's going to be working with 770 and 809. But you know, if you have been around a while, these kinds of names weren't associated with cystic fibrosis before. Now, people say, hey, wow, why are you all supporting Pfizer? Well, I was with Pfizer yesterday, and we created a bubble over a program. Big pharma fires people very easily. You know, if they don't like the program, they kick them out the door. What we've done is supporting people by supporting a Pfizer pharmaceutical company and a group of people. And, you know, this is unheard of. And that's created a momentum which is in partnership with the Cystic Fibrosis Foundation, because we support many of these programs to make all of this happen. But one of the things you probably don't know, and it's my last slide, and I won't be quite like Beth, after she says, well, I'm coming to an end here. And we went on for another 25 minutes. I knew when she said that. And that's when I went, I love her. We actually have our own laboratories now in Bedford, Massachusetts. And this is our new laboratory. You can see some of the lab space here, conference room space. But what we found out is many of the pharmaceutical companies, they shouldn't have to set up assays. If they got a compound, why should they have to set it up to test it? Why can't we do it for them? And so to accelerate, concept of acceleration is so important to the Cystic Fibrosis Foundation. And this is the laboratory space. I told them they should have put more people in here because I think we got 1, 2, but I will tell you, we were expanding from 17 to about 30 people here. And I tell you, they're doing work in stem cells, getting those airway cells out that might be the progenitor cells. They're doing cell banking, they're doing gene editing, sequences, and therapying. So they're doing everything that we need to do to continue to move our spectrum over to the left to a concept of a one-day therapy or a one-time therapy. So daily, weekly, bi-weekly, monthly, and now we want to move to. That's going to take a long time, by the way, folks. I don't want, one of my jobs is I can get pretty excited about what's going on. People say, oh, he's excited, and then he's 72 years old. This is going to happen in the next 5 years for this poor guy. Hey, this is going to take a while. What we're trying to do is going to continue to make these investments. They may be 15, 20, 25-year investments. Because if you remember, our first Aurora investment was 1999. First drug was approved in 2012, or Orkambi was approved in 2015. So it takes a long time, but we got to make these investments now. So obviously, my punchline is some of my wonderful friends, is can we do better? And I hope I've convinced you we can do better. We are doing better. I think the pipeline has never been greater for a CF, and the optimism that you have as parents, as caregivers, should be really something that you need to be excited about in terms of the future for all individuals with cystic fibrosis. And with that, I'm going to ask, do I have time for questions?
You do.
And I'll say thank you, so I won't forget my last slide. That Katie had a heck of a job yesterday at downloading. She was great. So any questions for me? Or I'll put it right back to Joel about any things that are going on down here. People understand where we're going? People excited?
Yes.
We've got a track record.
Very exciting.
And by the way, I'm going to go back to Terry a little bit here. Not to you, Terry, but I'm going to make reference to it. People saw a couple of years ago that we were able to monetize our future royalty rights and put $3.5 billion in the bank. We've doubled the support of our care center program this year. We're supporting about medical treatments. We're supporting the kind of things that's moving the pipeline back to a one-time therapy. We could exhaust that money if we lose our ability to raise money. And that's why it's so important. I mean, if you look at our burn rate, we are spending more money today than we raise. Our medical program in 2015 was the biggest before that. 2016 is going to be even bigger. And we're adding mental health people to the programs. We're adding pharmacists to the programs. We're burning at a rate. So money, as you all know, if it's, it sounds like a lot of money, but when you're burning rate of $200–300 million a year, and if things slow down in terms of fundraising. So did I tell them what I was supposed to say to that?
Yes.
Okay. Okay. Any questions?
Raising funds.
2 weeks for the first Virginia Great Strides Walk in Virginia Beach and in Lexington.
Can we do a cycle down here?
We do not recycle.
We have extreme hike. You want to do that?
Yeah. I can hardly hike over there. Thank you all very much. Really appreciate it.
Can I have my Twix now? You can have your Twix. We've got more. Thank you all for coming. Please fill out your evaluation form, drop it off at the check-in counter, and see if you want a door prize.
You want the same thing for the